content and the latent content. Everybody will understand. Everybody will understand. Unconscious content is screened by the subconscious level, and you are expressing in the conscious level by the screening method. But what Freud says, even in the unconscious mind, we have the screening method. We have a content, but in unconscious mind also, it is not expressed completely. It will manifest a dream in a different way. That is called manifest content. This is not explained by the neuroscience. Dream is explained by the neuroscience, but this difference between the latent content of the dream and the manifest content. For example, நான் இப்போ நான் ஒருத்தனை பனிஷ் பண்ணணும்னு நினைக்கிறேன், அது அன்கான்சியஸ்ல இருக்கிறது லேட்டன்ட் கண்டென்ட். ஆனா இந்த பனிஷ் பண்ணணும்னு இருக்கிறது ட்ரீமா வராது. சம்டைம்ஸ் ஐ பனிஷ் அன் அனிமல். See, நான் பனிஷ் பண்ணணும்னு நினைக்கிறது என்னோட ஃப்ரெண்ட, ஆனா நான் பனிஷ் பண்றது அனிமல. See, this difference not even explained by the neuroscience today, even at this artificial intelligence, all those things. So I always say Freud is ahead of times. Our psychiatrists nowadays, postgraduates, are more biological oriented. They say about biological psychiatry, but I used to teach them a lot of things about Freud. This is it's not moving. Am I audible? It's not moving. Slide.
Audible.
Slide. Yeah. See, the dream is processed in major lot of methods. This is processed because we have a lot of abundant material. I say 90% of our personality is under unconscious. So the unconscious material is processed. These are the three mechanisms. Lot of mechanisms are there. At least we should know these three mechanisms: condensation, displacement, representation. See, what is condensation? I used to condense two different content. For example, I have a friend of having an Audi car, and another friend is having a big house. But in dream, both are condensed, having a person having one big house and the Audi car. So this is way we used to condense the dream, condensed part. So it comes at you as a single dream, not as a different dream. So mainly I express the negative. So sometimes some people, they get positive also. Positive way condensation also will occur. But majority of the things under unconscious level, for example, 99% we have negative things. So I'm speaking about the negative things. Don't mistake me. But actually this is happening. So I have to project this. So then displacement. What is displacement? See, if I want to punish my father because my father scolded me. So in dream, I won't punish my father. I punish some other person. But my wish is punish my father. So this got displaced. This is called displacement. Representation. And what are the wishes we have? We don't represent directly. We represent through symbols. For example, Indian mythology, or if we go to Indian religious, what they say, when you are fearful, you get dreams about the snake. Snake is a symbol of fearfulness. People say, I saw a lot of snakes because he has a lot of fear. That is expressed by that is a genetic memory. Even if you don't see the snake in your lifetime, first time when you see, you become very much afraid. That is because of the genetic memory. So this is called a representation. So these are all the ways Freud said dreams gets processed. Then neuroscience. Now coming to the neuroscience, what neuroscience say, dreams is the mental process. Dreams is a completely 100% a mental process. We have got a lot of mental constructs. We have got emotions, emotional construct. We have got cognitive construct. We have got thought process. A lot of things are there. Lot of things. So we have got this mental process, that is 5 senses: intelligence, emotions, conflicts, environment, motivation, success. All those things altogether, they work and they produces the dream. This is what neuroscience says. See, this one picture I can easily example. See, something happened in the daytime. If it is processed, then it becomes memory, no problem at all. Whenever you see the same situation, the memory will bring that. You will remember that. For example, I go to a shop, I buy uldam paruppu and come home. And then during that night, I have this event is processed. I go to this Garden Fresh and I got uldam paruppu and I gave it to my wife. This is processed. This doesn't disturb me at all. See, but coming to this, something happened today. Morning, I went to a temple. I parked a car and I had a conflict with that security. So this disturbs me. This doesn't get easily processed. I will attach emotions, I will add cognitions, whatever happened in the past, all those things. So this event not processed, then it becomes dreams. See, try to understand these two slides. This is very important to understand the dream. This is enough to understand the dream. So a dream split up. We have everybody of all the past speakers told about the two types of sleep, REM sleep and NREM sleep. And usually what they say, REM sleep, we have dreams, that we have whatever thing, the mental memory consolidation or memory processing happens during the REM period. But we don't act out. See, jumping from the building will happen in the dream, but we don't jump. That is because you don't jump from the bed. That is because it is called paradoxical sleep. It's called a paradoxical sleep. So the whole body musculoskeletal system get fatigued or it becomes atonic. So we get dreams during the NREM sleep. See, sleep waves. See the sleep waves. First is awakened sleep. The same thing happened in the REM sleep. That is high frequency and low amplitude. When you have the NREM deep sleep, you have large amplitude and low frequency. See, nap dream. Morning also sometimes we sleep, no, refreshing sleep. Afternoon after having a lunch, தொண்டருக்கும் உண்டமயக்கம் உண்டமயக்கம் தொண்டருக்கும் உண்டு அப்படின்னு சொல்லுவாங்க, பழமொழியா இருக்கு. Those time you have less than 30 minutes directly go to the NREM sleep, and if you have long sleep, you go through the sleep cycle completely. And the type that dream may be any type. It is black and white dream or colorful dream, that you are moving with friends, or flying dreams, that you are flying from building to building, falling dreams, from a tree you fall, try to fall, and continuous fall, you don't touch the ground, macro size Lilliputian dreams, and the change of perceptions will also happen. That is, I eat music. Music you hear, you can't eat, but change of person, I eat music and I hear the yellow. See, how can I hear the yellow? I can see the yellow color, but in dream I can hear the yellow and I eat the music. So ununderstandable dreams, lot of things are there. These are the professional related content, academic content, relationship content, relations breakup, and sexual content usually happens in the adolescent age, and they have nightfalls and problem solving wishes. So Ramanujam asked a lot of the problem he solved only in the dream. Ramanujam, no, our great mathematician, problem solving content, wishes, curses, punishment, vivid dreams. And dreams has no limit, time boundaries. There is no time. Almost we lived 10 years in one day night sleep. One day night we slept and we dreamt about 10 years period. No space boundaries. We used to think of US or something, and no relationship boundaries and no senses. And it goes beyond the logic. And our rule, if the subject understand it is a dream after awakening, we have no rule. If patient understand this is a dream, leave it. If dream disturbs the subject, then we have a role that patient allow the patient to ventilate and reassure the patient, and try to instruct in about the sleep hygiene. Let them follow the sleep hygiene.
1 second, yes,
Then if it is disturbing, if drugs have very minimal role, that is for frequent awakenings, for anxiety, or they develop depression, or they develop acting out, then we have a role. That too very minimal. And I want to complete the dream by saying our Abdul Kalam, dream is not what you see in the sleep. Dream is something which doesn't let you sleep. So I will complete this sleep, and if the organizers permit, I will go to parasomnias. Otherwise, I'll complete the take-home messages. Dreams are helpful in learning and memory consolidation. Dreams are not always pathological. When dreams affect functionality, then only the intervention is needed. Shall I go to parasomnias? Organizers, shall I go to parasomnias?
Hari sir?
Shall I go to parasomnias, or shall I finish this?
Sir, you can just touch about it, about 1 or 2 lines on it and close it, because otherwise the whole session will go on.
Okay, sir. Right. Parasomnia is nothing. See, you should understand what is dysomnia. Dysomnia is a disturbance in the quality and the quantity. That is, I am not able to sleep. Onset is disturbed, frequent awakening, early morning awakening. Those things are all dysomnias. Parasomnias is entirely a different thing. That is behavioral problem happening during the dream. That is called parasomnias. See, parasomnias, the parasomnias, frequent awakenings. This is the normal awakening. See, you see 3 bars, no, 3 little thin bars. 3 times patient is awakening. So when it comes to having parasomnias, we have multiple awakenings. People who have multiple awakenings, they have parasomnias. Especially parasomnias affects the children group, younger age group. We have NREM parasomnias and REM parasomnia. NREM in children and REM is adult. Parasomnias are developmental and REM, NREM parasomnias are developmental and REM parasomnias are degenerative in nature. And it's common in children, developmental, and this is common in adults and degenerative. And NREM sleep is a motor, verbal, eating, or experimental, any behavioral thing, a semi-purposive or semi-experimental thing happens during sleep. It is called NREM sleep disorder. See, this patient, child may walk, child may talk, child may arouse, child may get night terrors. All those things are NREM disorders. So already Madam told about the diagnosis criteria. This sleepwalking, otherwise called as somnambulism, this is arousal associated with the ambulation and other complex behavior. Patient will get out of the bed and go to the wall and draw something, or go to the drawer and take a book, and go to the kitchen and take some food and eat. Anything may happen in the sleepwalking. And sleepwalking, the movement won't be there, but child will be sleeping, talking something. You may understand the talk or you may not understand the talk. Anything can happen. And confusion arousals, where a child is aroused, but child may not talk, child is confused, child is not out of the bed, but sleepwalk, child is out of the bed. That is the difference between confusion arousals and the sleepwalking. And sleep terror, see, this happens in NREM disorder, sorry, REM. Sleep terror is NREM. Sleep nightmares is REM. Sleep terror, child will suddenly scream. Everybody in the family will get up. And everybody will try to pacify. Something happened to the child. Child is bitten by something, or something fallen over the child. So child is so screaming. And if they go and see, nothing will happen. And child may not be able to explain. You won't remember anything. That is called that is called sleep terror. This is nightmare. This is a difference between nightmares and night terror. This is NREM. This is night terror is REM. Arousal, extreme shouting or screaming. And NREM night terrors is arousal is elevated. Here nightmares, they don't recall. Night terrors is recall. The mood here, it is fearful. Night terror is anxious. And age is adults and children. Night terrors is in children. Management, usually no treatment is required. All the children outgrow when they grow into the adolescent period. After 12 years, these incidents will slowly drop down. Only 4% they carry these symptoms to the adult period. Reassurance to the parents, good sleep hygiene, and avoid sleep deprivation and anticipated awakening. Anticipated awakening is the child do the behavior at the same time. See, for example, at the 1 o'clock child is doing, so mother should wake up the child by 12:30. So you can avoid that behavior by 1 o'clock. So anticipated awakening, that is the treatment. If at all you are a general practitioner unable to manage, refer the child to psychiatrist or pediatrician. Clonazepam is the drug of choice, and SSRI is sparingly used. And this is REM sleep disorder. This happens in the adult. This is a degenerative process. Something going in the brain organically. That is, you have Parkinsonism, you have any other degenerative changes, substance use, or something is there. Your brain is not normal organically. Then you have REM disorder. I told REM disorder is a paradoxical sleep. The whole body is atonic. You may be jumping from the wall. You may be jumping from the fifth story building, but you are not jumping out of the bed. That is because of the atonia. But in REM sleep disorder, atonia is gone. So when you jump from the building, you jump from the bed also. When you hit somebody in the dream, you hit your wife or the spouse who is next to. So wife get injured. So this happens in the REM sleep disorder. See, already Madam told this criteria, and this is a REM sleep behavioral disorder. The atonia is lost, exhibiting some behavior, some thrusting movement or beating movements or jumping, something may happen. This isolated sleep paralysis. See, this is fearful to the patient. This usually happens in the substance use disorder. See, either at the onset of the sleep or at the awakening. See, if patient is 100% conscious and is unable to move his hand or limb or unable to turn, see how much it will be fearful. You are unable to breathe also sometimes. This happens. This is called isolated sleep paralysis. And nightmares and nightmare disorder, already I explained. Management, same thing. Reassurance and sleep hygiene, safety measures. Only thing, when you see the REM disorder, think of degenerative disease, and the appropriate referral is the treatment of choice. See, this take home message. NREM sleep disorders are usually developmental in nature. REM is degenerative. Children would outgrow problem during adolescence. REM sleep disorder, early interventions are by the specialist is needed. Thank you all. These are my reference. Thank you for not dreaming.
Thank you so much, sir, for the dreamful and melodious presentation.
So I am Dr. Shankar Narayanan, the chairperson of this session. I thank Dr. Natarajan for the excellent lecture.
Thank you, sir.
All his history, diagnosis is by good history. The good sleep history will tell you whether it is a night terror or a nightmare. Everything depends upon the history, whether it is in the NREM or in the REM. So history will tell you the diagnosis. Now I will request the next speaker, Dr. Ashwin VG, for the polysomnography topic. Please introduce Ashwin, madam.
Yes, sir. Yes, sir. So our next speaker will be Dr. Ashwin BG. He is ENT and head and neck surgery. He's assistant professor in Stanley Medical College. Dr. Ashwin BG has done his MBBS in SRMC, MS ENT in Jawaharlal Nehru Medical College, Bangalore. He has also done his fellowship in France. He has got n number of workshops attended. There's a lot of publications. His areas of interest are functional endoscopic sinus surgery, endoscopic ventral skull-based surgery, endoscopic and microscopic ear surgeries, and head and neck surgery. We welcome you, sir. Kindly take us through polysomnography.
Thank you, ma'am. Am I audible?
Yes, sir.
Okay. Can I share this screen? Slides are visible? Are the slides visible?
Yes, sir. Please go ahead.
Okay, thank you. I immensely thank IMA for this wonderful opportunity. It's indeed a pleasure to deliver this talk in front of eminent speakers and delegates. There are a lot of developments in various specialties. The various specialties like ENT, neurology, gastroenterology, it's all based on multiple organ systems. But sleep is a biophysiological process. It is not based on a single organ system. So sleep disorders, sleep studies are studies of abnormalities in this biophysiological process. So we have to study a whole lot of parameters to come to a conclusion about the pathology of the disease. So based on this introduction, I would like to talk about polysomnography, which is the investigation of choice. It is the gold standard investigation of choice for diagnosis of sleep-related breathing disorders. I would like to start with this annotation from Tirukkural, Noi Nadi, Noi Mudal Nadi, Aditanikum Vai Nadi, Vaipachayal, which means you should know the disease, you should know the cause for the disease, and then only it is possible for proper treatment of the condition. So these are my objectives. I'll be doing the definition, the basic parameters of polysomnogram, the stages of sleep, sleep scoring, respiratory event scoring, and a few polysomnographic exercises will be demonstrated. So what is PSG? Polysomnography is a comprehensive recording of biophysiological changes that occur during sleep. PSG includes the identification of sleep stage, which stage of sleep the individual is in, and then the pattern of respiration during that specific sleep stage, and analysis of various movement patterns during that stage. So these are the various parameters which come under a routine polysomnography: electroencephalogram to measure the brain activity, electromyogram, usually the mentalis muscle, to determine the tone of the muscle, the nasal and oral airflow meters, and thoracic and abdominal movement. It is usually by thoracic and abdominal belts, and of late we use esophageal pressure monitoring, and then we check for the oxygen saturation by pulse oximetry, and then an electrocardiogram. Also, what is missing here is an electrooculography to determine whether it's a REM sleep or a NREM sleep. So this is a picture showing the various electrode placements in EEG of PSG. This F4C4O2, this frontal, central, and occipital leads on the right side are the actual recommended leads in comparison with M1, that is mastoid electrode on the left side. So F4M1, C4M1, and O2M1 are the electrodes of choice for recording EEG in polysomnography. This is a clinical picture showing O1 and O2 in a EEG. And these are the various other leads, the F3 and F4 on the left side, the F3 and C3 on the left side, and F4 and C4. And these are the electrooculographic leads, EOG lead on the right side, EOG lead on the left side, the EMG leads based on the mentalis muscle. So these are the various electrographic recordings. And then we also do the respiratory monitoring. Apnea, that is complete cessation of respiration, is monitored using an oronasal thermal sensor. And hypopnea, that is reduced airflow, is measured using a nasal pressure monitor. And respiratory effort, as I already told, is through a esophageal pressure monitoring. And in its absence, we can also use respiratory inductance, plethysmography, and diaphragmatic or intercostal EMG. That is by way of chest and abdominal belts. The arterial oxygen saturation is by pulse oximetry, and alveolar hypoventilation by end-tidal carbon dioxide and transcutaneous PCO2 monitoring. So this is the nasal pressure monitoring and oronasal thermal sensors, and this is the thoracic and the abdominal belts for monitoring the thoracic and abdominal movements during the stages of sleep. So the architecture of sleep, as the age progresses, there is an increase in stage N1 and N2, as the previous speakers had talked about. There is an increase in sleep latency itself. The onset of sleep itself is delayed as the age progresses. And there's a reduction in the deeper stages of sleep, that is stage N3 and REM. There is a significant reduction as the age progresses. Going on to the scoring of sleep stages, these are the various stages of sleep, stage N1, N2, N3, these are non-REM sleep. Before N1 will be the stage of wakefulness, that is stage W. And then after stage N3 will be the stage of REM sleep, that is rapid eye movement sleep. The entire sleep study is divided into 30-second sequential epochs. Every 30 seconds is a single epoch. So based upon the EEG tracings, we'll assign a stage to each of the epochs. These are the various wave activities which will be present on the EEG. Alpha activity are high frequency, high amplitude waves, which are around 8 to 13 hertz, usually prominent in the occipital reeds. These are seen in awake state. The theta activity, that these are slowing of alpha activity. There's a low frequency, low amplitude waves, 4 to 8 hertz. This is seen in N1 stage, as well as REM sleep, where there is a sawtooth activity. This theta activity has sawtooth pattern. That will be REM sleep. And then the sleep spindles. So these are phasic bursts of 11 to 16 hertz. You can see they have a spindle shape, and hence the name. And then the K complexes, they have a negative deflection with a positive component, and these are K complexes. Sleep spindles and K complexes are defining feature of stage N2 of sleep. And then slow waves, high amplitude slow waves or delta waves are a prominent feature of stage N3. And REM is characterized by the rapid conjugate eye movements on the electrooculography, and the slow eye movements, rhythmic slow rolling eye movements are seen in stage N1 of disease. That is from N1 of the sleep study. That is from wakefulness to the onset of N1. That is when you start seeing the slow eye movements. So these are certain examples. In stage W, you can see the alpha activity on all the leads, and most prominent on the occipital leads. And then E1 and E2 showing eye movements, and chin EMG is showing a high tone of the mentalis muscle, and this is a stage of wakefulness. And stage N1, there is a replacement of alpha activity by theta activity, and there is a slow eye movements, conjugate slow eye movements, and there's a reduction in the EMG tone in stage N1. And this is stage N2, which is characterized by sleep spindles and K complexes, and there is a further reduction in the tone of the mentalis muscle. Stage N3 are slow high amplitude delta waves, and there is electrooculography shows mirroring of these EEG activity, and the chin EMG is almost coming to the baseline. Stage REM sleep is characterized by the sawtooth activity, theta activity, and there is rapid conjugate eye movements, and there is absent tone, that is atonic chin reading on electromyography. Going on to scoring of respiratory events, you score a respiratory event as apnea when there is total cessation of airflow for a period of at least 10 seconds. And it is hypopnea when there is a reduction of airflow. There is no complete cessation, but there is a reduction of airflow for at least a period of 10 seconds. There is a picture showing an example of obstructive sleep apnea of the upper airway tract. How do you score an apnea? An apnea is when there is a drop in the peak thermal sensor exertion of more than or equal to 90%. That is when the airflow, nasal airflow is reduced to more than 90%, at least for a duration of 90 seconds, then we score it as apnea. So once the criteria for apnea is met, we have to differentiate it between obstructive and central. Obstructive apnea is when there is a continued or increased inspiratory effort. There is a respiratory effort by the patient with a falling, nasal airflow. A central apnea is when there is a complete absent respiratory effort. There is a complete cessation of breathing during this period. A mixed apnea is when there is absent inspiratory effort in the initial portion of the event, followed by resumption of inspiratory effort during the second portion of the event. Simply, it is a combination of central followed by obstructive sleep apnea. Scoring of hypopnea, how do you call it as a hypopnea? The peak signal excursions in the nasal pressure monitor, there's a drop of at least 30% from the baseline. That is, there is a reduction of airflow of more than 30% and for a duration of at least 10 seconds. And there is a drop in oxygen saturation of equal to or more than 3%. That is a hypopnea. Similarly, once hypopnea is determined, you have to differentiate it between obstructive or central hypopnea. Obstructive hypopnea is when the patient has a snoring event and a thoraco-abdominal paradox. That is, we saw the thoracic and abdominal bells, right? During a normal inspiration, there will be expansion of both the chest and the abdomen. Whereas during obstructive hypopnea, there will be an indrawing of the chest and expansion of the abdomen. That is thoraco-abdominal paradox, which typically happens during an obstructive hypopnea. When this thing is not present, that is when there is no snoring and there is no thoraco-abdominal paradox, then it becomes a central hypopnea. Respiratory effort related arousals. RERA, it is when there is the criteria for apnea and hypopnea are not met, but there is a sequence of breathing episodes lasting for 10 seconds with increased respiratory effort leading to awakening or arousal of the patient from sleep. There is no drop in saturation in these patients, but the patient is awakening from sleep. That is RERA. Going on to levels of sleep study. Based on these parameters, we do the sleep study. The level 1 is the gold standard, the polysomnography. It is a fully attended sleep lab polysomnography, having more than or equal to 7 channels in a laboratory setting. Level 2 and 3 are unattended polysomnography, which is a home sleep study. It can be done at the home of the patient itself. So these are the levels of sleep study. Level 1 is attended with 7 channels at least, EEG, EOG, chin, EMG, ECG, airflow, respiratory effort, and oxygen saturation. Level 2 is unattended, but has 7 channels, same as level 1. And level 3 is a cardiorespiratory monitoring, which has at least 4 channels. Level 4 is not of much significance for the diagnosis and management of sleep-related breathing disorders. There are a whole lot of infinite number of indices and parameters which can be picked up from a proper polysomnography, but the most important of them are apnea-hypopnea index and respiratory disturbance index. AHI is apneas plus hypopneas divided by total sleep time, and respiratory disturbance index is apneas plus hypopneas plus RARAS divided by total sleep time. Based on the AHI, we can divide the severity of OSA. Less than 5 is normal, 5 to 15 is mild OSA, 15 to 30 is moderate, and greater than 30 is severe obstructive sleep apnea. So what are the things to look for on a PSG report? The pattern of apnea and hypopnea, that is whether it's a central apnea, hypopnea, or a peripheral or obstructive sleep apnea. And then based on that, you have to find out the AHI or respiratory disturbance index. And then the central, if there are central apneas, then you have to determine the central apnea index, and then hypoxemia and hypoventilation if present. So these are some examples. This is a Obstructive sleep hypopnea. You can see there's a reduction in the nasal pressure monitor and nasal oral thermal airflow. Whereas you can see the chest and abdominal movements. There is thoraco-abdominal paradox. When there is a indrawing of the chest, there is an expansion of the abdomen. This thoraco-abdominal paradox is typical of obstructive sleep apnea and hypopnea. And once the respiratory event is over, you can see the return of the phasic potentials. You can see the chest and abdomen move in a phase. There is no phase differential between the two. This is an example of a central apnea. You can see there's a complete absence of airflow, and the chest and abdominal movements, there is absence of respiratory effort. These are all artifacts from the ECG leads. This is a typical example of Kinney-Stokes respiration. This is an apnea followed by a crescendo, decrescendo form of respiration, which is seen in central apneas most commonly. This is an example of mixed apnea, that is central apnea as well as obstructive apnea. You can see the respiratory efforts here, whereas there is no respiratory efforts in this part. There are certain recent guidelines put forth by the American Association of Sleep Medicine. I'll just give a gist. This is the 2017 recommendations. When a patient has a suspected moderate to severe obstructive sleep apnea without any comorbidities, especially cardiopulmonary disorders or stroke-like disorders, then patient can be suggested for a home sleep study. If there are any comorbidities associated with the cardiopulmonary system, then it's always essential to do a formal polysomnography in a lab setting. Another recent recommendation in June 2021, based on the follow-up polysomnography. When do you do a follow-up polysomnography? For all patients who undergo a PAP therapy, it is not always necessary to do a formal PSG or a home sleep study. In case of non-PAP interventions like surgery or sleep surgery or oral appliances, then you can do a follow-up PSG or home sleep studies. So this is my take-home message. PSG, of course, is the gold standard for diagnosis of sleep-related breathing disorders. And to determine the type of sleep-related breathing disorders, Level 1 PSG is attended lab study, which gives an accurate diagnosis. Level 2 and 3 home studies can be used in patients with no cardiopulmonary comorbidities. Formal level 1 study should be done in patients with high suspicion of OSA when they are negative on level 2 or 3 study. Thank you.
Thank you so much for that wonderful graphical presentation, sir. We saw a lot of graphs and graphics too in the form of transitions, sir. Over to LSN, sir.
Thank you, Dr. Ashwin. It was a very good lecture. The topic is a very difficult topic. The attending people are practitioners of various branches, but you have clearly taken pains to describe the various rhythms of the electroencephalography and how to differentiate between obstructive sleep apnea and central sleep apnea. It is a very without any confusion, it was a very clear lecture. Thank you for the same.
Thank you, sir. Thank you so much.
I invite Dr. Prasanna Karthik for the next topic on non-pharmacological management of insomnia. Madam, introduce him.
மேடம் நீங்க மியூட் பண்ணிட்டே பேசுறீங்க. You are not audible.
Now just go to the slideshow and
Yes,
keep
sir.
talking, Edil.
Yes, sir. Yes, sir. Am I audible now, sir?
Yes, yes.
Yes. Next speaker is Dr. Prasanna Karthik. Dr. Prasanna Karthik is Professor, Department of General Medicine, Savitha Medical College. He has done his undergraduation in PSG Institute of Coimbatore, post-graduation in Madras Medical College. He is American Heart Association trained instructor and provider of BLS and ACLS. He has more than 50 publications in index national and international reviewed journals. He has presentations too. He is member of American College of Physicians, Royal College of Physicians, London, Association of Physicians of India, Indian Society of Hypertension, and Indian Medical Association. His fields of interest: diabetes mellitus, cerebrovascular diseases, and autonomic function testing. Over to you, sir.
Good afternoon to one and all. Can I share my screen?
Yes, Prasanna, go ahead. Prasanna, it's not visible.
My screen sharing is open, but my slides are not coming up.
Sir, I will share someone's.
We have a backup. We'll share it from our end.
Yeah, I'll start from my side.
Yeah. You can start and we'll just start.
Is it visible, sir?
Illa, madam.
No, not yet. No, I think Dr. Prasanna has to log out.
Prasanna,
You stop screen sharing, then she can do.
Is it visible now, sir?
No.
One second, sir.
Is there in the group?
Yes, sir, it is there. I'm trying to share it, sir.
So Dr. Prasanna has to stop screen.
No, I've got it ready, sir, but
No. Dr. Prasanna has to stop sharing.
He is still sharing.
Hari sir, you can also try stopping that screen share, sir.
Illa. See.
So I have shut it down.
Yeah, fine. Now Edil can share.
So is it visible, sir?
Yes, ma'am. Yes, ma'am. Thank you very much, ma'am.
Sorry for the delay, sir.
Sorry, ma'am. Sorry from my side also. I apologize to all for the delay. Without much ado, I wish all a very good afternoon. And I'm here to talk on this topic, non-pharmacological therapy of insomnia. Now we have had a wonderful series of lectures on sleep and sleep disorders. So I would like to go through my slides. Next slide, please.
Madam, next slide.
Stuck, sir, once.
So the outline of my talk will be on these headings. I will talk to you a few slides on sleep hygiene, what is sleep restriction, what is stimulus control, relaxation techniques. Then I will move on to the cognitive therapy and cognitive behavioral therapy. And my last slide would be on the advantages and disadvantages of non-pharmacological therapy. Next slide, please. So non-pharmacological therapy has a major role in management of insomnia, but it is also along with and without pharmacological therapy. Some of the common things that we need to advise to our patients is about how they should attempt to maintain a regular sleep-wake cycle. That means going to bed on the right time and getting up on the right time. That makes very, very important, and rather avoid various in the times of sleep. It is also important that they go outside in the morning to expose themselves to the sunlight. This helps in establishing the circadian rhythm and the melatonin cycles. And the bedroom should be used only for sleep and intimacy and not for other work like work. It is also important to make sure that the bedroom is also quiet, comfortable, and dark, and the temperature is neither too hot nor too less.
790.
And it's also very important that they develop a relaxing routine within an hour before bedtime. That means they should start avoiding all gadgets and probably go to bed where they go to sleep with a book or a cup of milk or something like that, and avoid unnecessary work in the bed. And they can exercise regularly. Regular exercise enhances sleep, but not during the evening time or just before bedtime, wherein the arousal will be there and they will not be interested to sleep after that. Next slide, please. They need to avoid alcohol and other addictive substances, and it's also necessary that they avoid caffeine and nicotine, especially in the evening time. And as such, please avoid heavy meals and usually take dinner 2 to 3 hours prior to their bedtime on regular times. Daytime napping is definitely to be avoided because that will cut short into their time in their sleep. And if possible, do not allow for phones to ring during the nighttime, especially if you're suffering from insomnia. And as I said, we need to avoid gadgets and kind of arguments inside the bedroom. And if you keep a clock, let it not be very close to the bedside so that every time you wake up, you don't look at the clock. The clock should be unobtrusive. It probably should be at the head end of the patient. And if you're more than 20 minutes awake in the bed, please avoid it. Rather go out and start doing something. Next slide, please. This is one of the commonest ways in treating insomnia. If we are doctors and as a physician, if you read Harrison, I'm sure within the first 30 minutes, we'll all start sleeping. But reading literature is a good idea about going to sleep. So it does help in treatment of insomnia. Next slide, please. Next slide, please.
Madam, next slide.
Okay, sir. Okay. Thank you, sir. ஆமா 2016. ஆமா நான் உங்களையும் எங்கேயோ பார்த்த மாதிரி தான் இருக்கு.
சார் நிர்மல் சார் உங்ககிட்ட ஸ்லைட் இருக்கா?
Not this PPT. If you can share, I can download and start sharing. I think Ariel is logged out.
She went out. Okay. 1 second, sir. I'm taking.
Sir, can you make me co-host, sir? I can share. I have sir's presentation.
Yeah, I think Sripara madam, you can start sharing.
Yes,
right
sir.
now.
I'll do that, sir. I'll do that.
Yeah, you can.
Sir, am I audible, sir?
Yeah.
There was some problem with my internet connection. Sorry, sir.
Ready, sir.
Just go down few slides. Yeah. One more.
Okay.
Next.
One, thank you.
Thank you.
Okay.
Yeah.
Ma'am, one
Yeah.
slide ahead, please.
One side.
Yeah. The most important thing that we need to remember is that sleep hygiene alone may not improve insomnia in all patients, but it is necessary that it should be always attempted in every patient. This is because most of the patients who suffer from insomnia already have had these bad habits, and these bad habits tend to be practiced over and over again. So now they find it to break it, and that's probably contributing to their insomnia. But it is necessary that we go and educate our patients about sleep hygiene. Next slide, please. The next technique that we should remember is sleep restriction. This is important to note that the amount of time that the patient spends in the bed is actual amount of time slept asleep. So if, for example, if the patient says, I go to bed at 10 o'clock, I fall asleep by 12 o'clock, and I get up at 6 o'clock, that means they've slept only for 6 hours. So patient should not go to bed before that 12 o'clock. So we need to restrict the time spent in the bed. Now, as the patient starts getting used to sleeping more and they say they are sleeping 1 hour extra, probably we can ahead the time at which they go to sleep. Next slide, please. So we need to delay the patient's bedtime. So if the patient says, I'm going to sleep only for 3 hours, probably they need to be awake till the time that they are going to awake. So if they're going to wake up at 6 o'clock and then you subtract from it 3 hours, so they need to go to bed at 3 o'clock. What this does is it increases the sleep drive. By making the patient awake, it makes them increase their sleep drive so they sleep better. And it also prevents the patient with insomnia from coping by catching up on their sleep. So if they go to bed at, say, earlier and they sleep for 3 hours, wake up, and they're not going to catch up on their real sleep, they'll have some more time to catch up. This we avoid by making sure that they don't go to sleep till the time window opens. Next slide, please. So if you can't sleep, go active, engage yourself in some other activity and don't go to sleep till you have the sleep window open. Next slide. The other is called a stimulus control. Now this is important because we need to train the patient who has insomnia to reassociate the bed and bedroom with sleep. Now this is important because they need to understand that the bed is associated with sleeping and not the negative connotations. They need to go to bed only when sleepy and not just because it's 10 o'clock on the cloud. And if you're not able to sleep, just get up and go ahead and do something else. And the bedroom should be used only for sleep. It should not be meant for reading books other time in the daytime. And please get up at the same time every morning. Don't catch up on sleep subsequently. And please avoid napping. That is very, very important. Next slide. What happens is this helps the brain to establish positive cognitions and break the negative cognitive associations which are associated with bedtime. So whenever the patient has insomnia, the brain associates the insomnia, the bed and the bedroom with frustration, wakefulness, and anger. So the patient will not fall asleep over a period of time. So now when we do the stimulus control, these negative cognitions are lost and the patient associates with a positive cognition. Next slide. The other things that we can also teach these patients is relaxation techniques. They are aimed at reducing somatic tension or intrusive thoughts which occur in the bedtime and that interfere with sleep. The major area is that there is a reduction in the basal level of arousal and direct impact on the sleep quality itself. But once the basal level of arousal decreases, generally sleep tends to occur better. Some of the things that we do is diaphragmatic breathing exercises, guided imagery, meditation, progressive muscle relaxation, and biofeedback. Next slide. I have a special word about biofeedback. It is about giving visual or auditory feedback to patients to help them control parameters like muscle tension. For example, we can identify when the patient's muscles become taut during insomnia and give them a small auditory sound so that the muscles relax. So when we train them over and over a period of time, they tend to relax their muscles, and these relaxation techniques help them to improve their insomnia. A special type of biofeedback is the EEG neurofeedback training. Now, this goes even a step ahead. It monitors the EEG of the patient, and thereby they get impulses, they get feedback through visual or auditory routes based on the cortical activity of the brain. Thereby, we can identify which particular abnormal frequencies are making the patient develop insomnia. Next slide, please. So, techniques that people do think is imagine sheep jumping over a wall and count the sheep that goes on. And if you keep on doing it, probably the sheep might fall asleep, you may not fall asleep. This is because while learning relaxation techniques is not very difficult, it takes consistent practice to achieve the sense of mastery, thereby making it useful to reduce insomnia. Next slide. Now, cognitive therapy is also something similar to this, wherein the negative thoughts in the patients are addressed. For example, the patients who cannot sleep say, if I get up from sleep, I cannot go to sleep. They have this definite preformed idea in the brain. So if this my sleep is disturbed, I cannot sleep. So these negative ideas in the brain have to be cleared. And they also have misconceptions about sleep, saying that they need to, sleep for 12 hours, they need to sleep for 4 hours, all these things. And they also think, what is the cause of it? They will say they'll attribute the bed. All these negative ideas need to be cleared in these patients. Next. The patient usually needs to work with the psychotherapist to explore the utility and validity of these faulty cognitions. They need to understand that what their brain is doing about it is negative, and they need to overcome these to overcome the anxiety associated with insomnia. Next slide. One of the special techniques in cognitive therapy is paradoxical intent. This is based on the premise that whenever a patient is going to go to sleep and they know that they are not going to get sleep, their anxiety increases. So the patients are instructed to do the opposite. That means they have to stay awake. So when they stay awake, all the anxiety starts deteriorating in regards to insomnia. But this technique is useful only to sleep initiation insomnia and not sleep wakefulness insomnia. Next slide. The last component is the cognitive behavioral therapy for insomnia. This is a combination of both cognitive as well as behavioral interventions. It's a combination of multiple techniques. The cognitive component is aimed at changing the patient's beliefs, and the behavioral component can be like the stimulus control therapy, sleep restriction, or relaxation training. Sleep hygiene education is also included. The most important thing about cognitive behavioral therapy for insomnia is that it is now becoming accepted among more and more psychologists and psychiatrists as one of the better therapies for insomnia, because a single therapy is not adequate to overcome insomnia in most of these patients. So combination therapy is always better and makes the patient achieve more success. Next slide. For the last set of my talk, what are the advantages of the non-pharmacological measures? It is less addictive and behavior forming than pharmacotherapy. It also addresses the primary underlying disorder in most patients with insomnia, which is a problem in either the cognition or the behavior. Next slide. Looking at the disadvantages, it is not an immediate response the patient will have. It does require a lot of time. Unlike when you take pharmacotherapy, wherein there can be the gain in sleep onset or total sleep time very rapidly. The second and most important thing, continuous patient motivation and encouragement is required. The patient has to continuously work with the psychotherapist or the psychologist and get things done. And they are more expensive and time consuming in the sense that they have to meet with a psychologist or a psychotherapist and go through multiple sessions rather than popping a tablet every day. And last but not the least, it requires the availability of a skilled therapist in cognitive behavior therapy to work with patients to help them overcome insomnia. Next slide. So my take-home messages for the lecture are: pharmacotherapy is currently the most common treatment modality for insomnia. Long-term use of hypnotics in chronic insomnia can become complicated by drug tolerance, dependence, or rebound insomnia. Psychological and behavioral therapies produce reliable changes in several sleep parameters of individuals with primary insomnia. Behavioral intervention should be used in every patient of insomnia. A combination of techniques called the CBTI, cognitive behavior therapy for insomnia, is now becoming the standard of care and is recommended by many academic bodies. With this, I take this opportunity to thank the organizers of this meeting for having given me an opportunity to address this crowd. Thank you all.
Thank you so much for that excellent presentation, sir. Once again, I'm extremely sorry for the hiccups from my side.
I'm also sorry for the hiccups from my side. Thank you.
Oh, in spite of
the lesson, sir.
In spite of the disturbance, Dr. Prasanna Karthik has given a very good lecture. Normally, we used to say cognitive behavioral therapy in many diseases, but now he has clearly explained what is meant by cognitive behavioral therapy. And for all diseases, we used to say non-drug treatment for likewise for insomnia, we have to insist on non-pharmacological management. Patients will expect some drugs to help them. That is patient's nature. Only the medical practitioners have to highlight the importance of non-pharmacological management of any disease, more so insomnia. Thank you, Dr. Prasanna Karthik.
Thank you, sir.
Thank you. Now I call upon Dr. A. Rukmani for the topic of prescription for a good sleep. Madam, introduce her.
Yes, sir. So is it visible, sir?
No, not at all.
Not yet. You can read from the slide and let Madam start sharing.
Okay, sir. Dr. A. Rukmani is Professor, Head of Department of Pharmacology at Chettinad Hospital and Research Institute, Kalambakam. Madam has done her MBBS in Madurai Medical College, a diploma in dermatology at Madras Medical College, and then MD Pharmacology in Madras Medical College. Madam has authored and edited one book, contributed one chapter in the book also. She has a number of research articles published, more than 65 papers in international and national journals. Madam is a recipient of Indian National Science Academy Fellowship in 1999. She has membership in various academic organizations. She's life member of Indian Pharmacology Society, life member IMA, member Indian Association of Dermatologists and Venereologists, member Indian Ethnopharmacology Association. We welcome you, ma'am, to give us a prescription for good sleep. I humbly request audience not to follow the prescription right now. Over to you, ma'am.
Ma'am, unmute பண்ணுங்க ma'am.
I thank the organizers, IMA Tambaram, Dr. Nirmal Frederick, the organizing team, and the organizing secretary, Dr. Hariharan, for giving me this opportunity to address today on prescribing for insomnia. Share the screen. Able to see the screen?
Yes, ma'am.
Yes, madam.
Thank you. So the topic given was prescription for good sleep. So I have modified a little to prescribing for insomnia. So we cannot say a prescription good or not good. In that sense, I have modified the title. The presentation will include a brief introduction, the pharmacological agents that are available, and how to prescribe for different types of insomnia, and a few questions to the participants, of course. So introduction, I think introduction has been given by many speakers. So I will skip the first slide regarding the definition of insomnia. With regard to pharmacological management, knowing about certain types of insomnia is important. One is sleep onset insomnia or initial insomnia, because this type determines which group of drugs we are going to choose. So sleep onset insomnia, otherwise called initial insomnia, they have difficulty in getting into sleep. And sleep maintenance or middle insomnia, difficulty in maintaining sleep. Late insomnia means they'll be waking up very early, not able to go back to sleep. So these are the three types of insomnias: early onset, middle, and late onset. And we can also classify insomnia into acute and chronic. Of course, the definition of acute and chronic varies from text to text and article to article. Some textbook says acute insomnia means more than 3 weeks or 1 month, not more than 3 months. So I leave the definition here. Short period is acute insomnia. And chronic insomnia means more than 6 months. That's what most of the literature say. But this chronic insomnia can be associated with other conditions where there is hyperactivity of stress response mechanisms can be involved, as in anxiety or depression, or any abnormality in the circadian rhythm, or there could be some precipitating factors like fatigue or chronic irritability, behavioral changes, cognitive characteristics. So all these contribute to chronic insomnia. There is another condition called associated insomnia. This can be an associated disorder along with mood disorder, like in depression or anxiety or schizophrenia. And it will be associated with, in most of the patients, inadequate sleep hygiene, about which the previous speaker and earlier speakers have spoken about. And the contributing factors for associated insomnia include consumption of stimulants, which has been discussed already, like caffeine, nicotine, alcohol, vigorous physical activity near bedtime. So you play a game or run and come back to sleep means it is not possible. And concomitant medications, they would be taking, especially in the elderly, they would be taking many medications which can act as CNS stimulants. For example, in bronchial asthma, they may be taking beta-2 agonist like salbutamol, which can be a stimulant. And use of substances like alcohol or other CNS stimulants like amphetamine, even antidepressants, can contribute to insomnia. So these are the various types of insomnias that will decide what treatment we are going to provide. A little bit of neurotransmitters. I think Dr. Balaji touched upon this. So GABA, all of us know, is an inhibitory neurotransmitter. All others stimulate neurotransmitter, including histamine, norepinephrine, acetylcholine. Of course, serotonin has a dual role. It can contribute to sleep or it can disturb sleep also. And orexin is a stimulant produced in the hypothalamus. And melatonin, of course, contributes to circadian rhythm. So the drugs that we are going to use are going to target these neurotransmitters. Either these drugs will facilitate the activity of GABA or inhibit the activity of the stimulant neurotransmitters. So the aim of pharmacotherapy will depend upon the age of the patient, the type, whether it is early onset, middle or late onset. What is our treatment goal? The treatment goal is to provide good sleep, prevent daytime drowsiness, and prevent anxiety, prevent their performance. That's what the treatment goal should be. And past treatment response, whether they had been suffering from insomnia earlier and what was their response to earlier treatment, depending upon that, we can decide the current treatment. And comorbid conditions, contraindications. Several drugs are contraindicated. For example, this anti-insomnia drugs we cannot be using in myasthenia gravis. So what are the contraindications and concurrent medication, and of course the potential adverse effects or safety. All these will decide the selection of drugs. So what are the drugs available in general for insomnia? This is a collective list. We'll be discussing the individual types subsequently. The benzodiazepines, all of us know benzodiazepines is the major group used in insomnia. There are several benzodiazepines. Among them, these are recommended in various clinical guidelines for treatment of insomnia: triazolam, estazolam, temazepam, quazepam, and flurazepam. Non-benzodiazepines, otherwise called Z drugs, that includes zolpidem, zaleplon, and zopiclone. And melatonin agonist, ramelteon, tasimelteon. Melatonin controls circadian rhythm. So these drugs will facilitate the functioning of circadian rhythm. Certain antidepressants, of course, antidepressants can act as stimulants. For example, fluoxetine, venlafaxine, these can act as stimulant. But drugs like doxepin, trazodone, metrazepine can be used in insomnia, provided the patient is suffering from anxiety and lack of sleep. And orexin receptor antagonist, suvorexant. This highly favorable drug recommended of late for insomnia. And of course, there are certain atypical antipsychotics like quetiapine. When the patient is suffering from psychiatric disorder as well as insomnia, the preferred drug is quetiapine. Antihistamines, of course, antihistamines are used as off-label drugs, which include diphenhydramine, hydroxyzine, and doxylamine. And certain herbal agents, natural remedies are also available, any number of natural remedies, but among them, valerian has been evaluated in many clinical trials for its action in insomnia, of course, ginseng also. These are the list of drugs available. Well, this is where the drugs are going to act in various areas in hypothalamus, thalamus, reticular activating system. So I'll skip this for want of time. So now coming to the individual drugs. First, for onset insomnia, that means a person is suffering from onset insomnia if the individual is not able to go to sleep within 30 minutes. That's called onset insomnia. For onset insomnia, the drugs recommended are Z drugs. Under that, zolpidem, zaleplon. So zolpidem comparatively longer acting than zaleplon. So zolpidem is given initially as 5 milligram, and we can go up to 10 milligram, but not to give more than 10 milligram, considering the safety. And the side effects include, like any other sedative or hypnotic drugs, drowsiness, dizziness, diarrhea. So we have to explain to the patient that they may have these problems. Of course, all these drugs, not only Z drugs, when in patients with hepatic disease or renal disease, we need to give a lower dose. Zaleplon, shorter half-life. So very good drug for short-term insomnia. Suppose the patient is suffering for 3 days or less than a week insomnia. We can give a short-acting drug. In that, zaleplon is recommended, and the initial dose is 10 milligram. And we can increase the dose by 5 and not to give more than 20 milligram. And the risk is same as that of zolpidem. Ramelteon is recommended dose is 8 milligram. And ramelteon, any drug, not only ramelteon, especially ramelteon, should be taken within 30 minutes before bedtime. And it should not be taken immediately after a high-fat meal, because that will interfere with its absorption. All these drugs, alcohol use should be avoided. And another benzodiazepine, triazolam, the recommended dose is 0.125 to 25 milligram. These are the drugs for onset insomnia. Now, onset and maintenance insomnia, what are the drugs we can use? Under this, most of the benzodiazepines are used for onset and maintenance because they are comparatively longer acting than the Z drugs. And of course, there are differences that we will discuss. So the longer acting drug is flurazepam, 15 to 30 milligram can be given. Temazepam, 15 milligram, we can go as low as 7.5 milligram. Then triazolam, 0.125 to 0.25 milligram. And estazolam, a little longer acting than temazepam and triazolam. So the duration of action is important for the selection of the drug. For maintenance and late insomnia, we can choose the longer acting drugs, whereas for onset insomnia, shorter acting drugs. Similarly, quazepam. Of course, quazepam is the drug contraindicated in OSA. If the patient is having obstructive sleep apnea, among the benzodiazepines, quazepam should not be given as it interferes with pulmonary function. Zobiclone, moderately half-life is 6 hours, and it is preferred for elderly patients. Zobiclone is a derivative of estazolam, so it's indicated for elderly patients. And suvorexton, orexin antagonist, 10 milligram dose, and hepatic and renal impairment, these drugs dosage should be adjusted. And the longer acting drugs are preferred in the elderly because that will reduce the daytime anxiety. Most of the elderly patients will be having anxiety about their sleep or about their disease. So longer acting drugs are preferred for the elderly patients who suffer from both onset and maintenance insomnia. And one drug that is recommended only for maintenance insomnia is doxepin. Of course, doxepin, because of its antihistaminic action, it provides sedation and it should not be given within 3 hours. And all these drugs should be taken within 30 minutes before sleep. Whether it is early insomnia, middle insomnia, or late insomnia, for transient insomnia lasting less than 3 days, we give triazolam and temazepam. For short-term insomnia, less than 3 weeks, temazepam, flurazepam, or estazolam. Long-term insomnia, flurazepam, longer acting, so it will continue daytime also. Provided in the elderly, we don't mind them sleeping, we can give longer acting drug. So to combine all this together, what are the salient characteristics of all these drugs? So benzodiazepines, most of them prefer for maintenance and onset insomnia as well as late insomnia, benzodiazepines. But the problem is rebound insomnia. So tapering of these drugs is essential. And is it drugs short-term therapy, 7 to 10 days? There is no rebound insomnia. That is the advantage. And the Remeltion, both acute and chronic insomnia, very good drug, no tolerance even after 6 months, does not interfere with the next day function. And tasimeltion, please remember, blind people suffer from what is called non-24-hour circadian rhythm because there is no dark and light cycle for them. If they suffer from insomnia, the drug recommended is melatonin analog, that is tasimeltion, 20 milligram. So this one of the natural drug, valerian, well evaluated in clinical studies, 300 to 900 milligram is found to be effective, but not yet used as a hypnotic right now. And these medications, I have already told you which are the medications that may interfere with the sleep. So to summarize, the first line pharmacological therapy in general are the Z hypnotics, the zolpidem, zaleplon, zobiclone. And the incidence of adverse effects is lower with S hypnotics. And 2 is Z hypnotics, zolpidem ER extended release formulation and S zobiclone are used for chronic insomnia, though they are indicated primarily for acute and onset insomnia. So the take-home message is insomnia is treatable provided the drugs are selected rationally. The pharmacological agents have to be used for the shortest duration possible, initiated in low doses and titrated to the lowest effective dose to minimize the development of dependence and reduce the risk of adverse effects. In general, short-acting drugs are preferred in sleep initiation, intermediate acting for maintaining, long-acting when patients complain of early morning awakening. Medication should be withdrawn slowly to avoid rebound insomnia. And lastly, patient education on the expectations of treatment and possible adverse effects can help maximize treatment outcomes. So I have put these questions for the participants. If any one of you is willing, can answer. So which drug is preferred among the Z drugs for acute onset insomnia? Can anybody tell?
I think all of them slept off, madam. Very
For
effective,
patient,
very effective prescription.
That is not at all a compliment, of course. For a patient above the age of 80 suffering from anxiety, will you give a short acting or a longer acting hypnotic?
Longer acting, ma'am.
Very good. How will you withdraw the above patient from the hypnotic agent?
Tighter and taper the dose.
That's where the question is tricky. For 80-year-old patient, we need not taper and withdraw. The quality of life is more important. So we need not withdraw. We can maintain them on low dose. And which drug can be used in a blind person suffering from insomnia?
Tasmaliton.
Nice. Thank you. Thank you for your active response, and thank you all.
Thank you so much for that excellent presentation, ma'am. You ensured that nobody followed your prescription with that interactive session. Thank you so much, ma'am.
Thank you.
Thank you, madam. It was a very good lecture. But many are interested. What about diazepam, clonazepam, all those drugs which are usually used in the day-to-day practice?
Yes, sir. For want of time, I'm not discussing because the bell is ringing. I know most of them use diazepam. It's longer acting. The half-life is 3 days. So rebound, insomnia, skeletal muscle relaxation, respiratory problem, all these will arise in the long run. And most of the prescriptions have alprazolam. Alprax, very famous for insomnia. That is not at all recommended for treatment of insomnia. And it is recommended for anxiety and panic disorder, not for insomnia. But most of the prescriptions, I have seen more than 100 prescriptions containing alprazolam prescribed for 3 months, 6 months like that.
Clonazepam, madam?
Clonazepam is also long acting. That is recommended in patients suffering from epilepsy or psychiatric disorder associated with the insomnia. These are the common drugs recommended in all the clinical guidelines, Indian guidelines, American guidelines, European guidelines. So it's a combination of all, and these are my references.
But these drugs are not available in the market. That is the problem, madam. All these drugs, what you have enumerated,
available, sir. Suvorexton is available. Ramelgion is available. I checked. I didn't want to show the brand names because that is not appropriate. But these drugs are available, sir. Zaleplon, Zolpidem.
Thank you, madam. It was a very nice lecture, very useful lecture. You have calmly said everything in detail. We are able to understand. Thank you.
Thank you, sir. Thank you.
Now the last lecture will be role of surgeons in sleep disorder by the eminent ENT surgeon, Dr. Shakti.
Sri, can you please share the slide?
Yeah, that's what I'm looking for. Not getting that.
You got it. Slideshow.
Phone where
So the last speaker of this session is Dr. K. Saktish, MS ENT. Is ENT, head and neck surgeon, snoring and obstructive sleep apnea consultant. He's consultant and director of Hopkins ENT, Chennai. Dr. Saktish has done an MBBS in Chengalpet Medical College. His MS ENT in Madras Medical College. He has done his fellowship in Philippine Society of Snoring and OSA Manila. Dr. Saktish has got various presentations. He has attended n number of conferences and surgical workshops. He has been invited as guest lecturer not only in the national conferences but also in the World Congress of Endoscopic Ear Surgery in Dubai. His special interests are snoring and sleep-related disorders, endoscopic ear surgery. We welcome Dr. Saktish to deliver his speech. Over to Dr. Saktish.
I'll start sharing my screen, madam. So it's a great pleasure and pride to be presenting after my pharmacology professor, Dr. Rukmani madam. So seeing madam after a very long time, it just brings back so many happy memories. It was very good to hear madam's crisp and immaculate English after a very long time. And not just pharmacology, she has been a person who has instilled social responsibility to us. I happen to be the narrator of our Tirukuttus, so which we enacted in several places across Chengalpet and Tambaram regarding the awareness regarding personal cleanliness. So very happy to be presenting after madam. So I've been given a task to speak about the role of a surgeon in management of the sleep disorders. It's a very big topic to cover in 15 minutes. So I'll try to stick on to just giving you an overview about what surgery can do to a patient with obstructive sleep apnea. So as you might have realized with all these topics that we have discussed today, sleep is the golden chain that binds health and our bodies together. And of course, sleep deprivation can hurt. So if you take obstructive sleep apnea, there are basically 4 reasons why a patient can have obstructive sleep apnea. These 4 reasons can play varying levels of role in each patient. So the first and foremost is a small and collapsible airway. The next would be an upper airway dilator muscle dysfunction, low arousal threshold in response to negative airway pressure, and finally, a very hypersensitive chemoreceptor triggered ventilatory drive, which is referred to as high loop gain. So when we talk about the role of a surgeon, it's not just about doing surgery. So it just starts at the evaluation of the patient itself. So the surgeon has a clear-cut role in play in diagnosis, and then comes the treatment. So when we talk about diagnosis of obstructive sleep apnea, so the first would be a clear-cut history from the patient and as well as the bed partner. Then you have a physical examination, then a complete upper airway assessment using nasopharyngoscopy. Then we do polysomnography. So many times we consider that polysomnography, yes, it is the gold standard evaluation for obstructive sleep apnea, but the evaluation does not stop with polysomnography. If you stop with polysomnography, your evaluation is still incomplete because there are certain patients who will not tolerate CPAP, or there are patients who can worsen with CPAP. So you have to have an anatomical diagnosis. Polysomnography gives you a physiological or a quantitative diagnosis of obstructive sleep apnea. So you need to have anatomical and a qualitative diagnosis, for which what is known as a drug-induced sleep endoscopy is the advised protocol. So in drug-induced sleep endoscopy, what we do is we sedate the patient usually with a drug which is called as Dexmed, which closely mimics a natural sleep. So we follow a standardized protocol which is called as VOTE classification. VOTE stands for V for velopharynx, O stands for oropharynx, T for tongue base, and E for epiglottis. So each level is systematically assessed for the presence or absence of collapse, the type of collapse, and the degree of collapse. So you can have an anteroposterior, you can have a lateral collapse, you can have a concentric type of collapse. And depending upon the degree of collapse, you give 0 for no collapse, 1 for partial collapse, and 2 for complete collapse. So this is a palatal collapse in the anteroposterior dimension. So you can see the palate is collapsing in the anteroposterior direction. So this is an example of palatal collapse in the lateral direction. You can see the lateral pharyngeal walls come into contact with each other when the patient is going through an apnea. So next you have a tongue-based collapse. Apart from having a lateral collapse, the patient is also having a tongue-based collapse. As you can appreciate, the valvula is completely occluded by the base of the tongue, and it is also seen pushing the epiglottis posteriorly. And this is a classical example of an epiglottis collapse. As you can see, the epiglottis is completely choking the airway whenever there is an inspiratory effort. So if you take these two examples, a patient with tongue-based collapse will not benefit much from CPAP, and a patient with epiglottis collapse will actually do worse if you give him CPAP. So the treatment options, traditionally we have 4 treatment options. Number 1 would be positive airway pressure devices. Number 2 is oral appliances therapy. Number 3 is surgery. And number 4, finally, pharmacotherapy, though traditionally drugs don't have any role in obstructive sleep apnea. Nowadays, there are a lot of drugs in terms of weight management, weight reduction drugs, and there are drugs which alter the arousal threshold and as well as the high loop gain. So when we come to treatment, the gold standard of treatment is CPAP. There is no controversies on that. So the positive airway pressure devices are the gold standard. What I mean by gold standard is gold standard treatment is one which can give relief in most of the patient for whom you administer. But that is not the entire picture that we have to see. So surgery, we have certain logics why we choose surgery in a patient who has obstructive sleep apnea. And of course, there are limitations to surgery as well. So the number 1 reason why we have to choose surgery as a treatment option is, see, I am a surgeon, but I would be very frank with you. All my patients, unless they have any contraindications to use CPAP, I offer them CPAP as the first treatment option. But the problem is the internationally published and the practically what we see is the long-term compliance of positive airway pressure is very low. It is roughly around 30 to 40%, which is very bad in the long term. And our patients have another concern as well. So when we have young patients, when we offer CPAP, the first thing they say is, if you ask me to use this kind of a machine every night I sleep, how can I get a girl to marry? So this is the first question that they ask. They outright deny or decline using CPAP. So that is the number 1 reason why we have to think about alternative to positive airway pressure treatment. And like I mentioned, there are certain patients who will not tolerate positive airway pressure. And then how surgery works? Surgery works by improving the upper airway dimension and the airway stability. And there are patients who have high BMI, the obese patients. These obese patients will not do well either with an upper airway surgery or CPAP. So those patients, you have to manage the weight before you do anything else. So, and next, we come to the limitations. So the pain and recovery, on an average, if you do any upper airway surgery, the patient is going to have 3 weeks of downtime and with 2 weeks of intense pain. So then you have comorbidities and surgical candidacy of the patient. Then you have complications, but complications nowadays with improved visualization and operating tools, the complications have almost ceased to exist these days. Then see, not all surgeries for obstructive sleep apnea can be done in a single stage. We have certain surgeries which has to be done in a phased manner. So patients should be prepared to undergo these multi-stage procedures. So when we talk about obstructive sleep apnea surgeries, you have 2 types of surgeries. One is improvement of airway collapse, and another is those surgeries which aim at reducing the weight. So you can see the surgeries, upper airway surgeries will restrict to that. So upper airway surgeries, you can see them as 2 types, those which address the box and those which address the content. Here, I mean the box by the upper airway. So the box is the craniofacial structure which supports the upper airway. So these are the craniofacial surgeries which improve upper airway stability. And then you have the content surgeries which address the soft tissues of the upper airway. So this is the modern algorithm for obstructive sleep apnea surgeries. We have two-phase surgeries. You have phase 1 surgeries, you have phase 2 surgeries. And the number one determinant of which treatment we give is depending apart from the evaluation, patient preference is given highest priority. If the patient is comfortable with CPAP and the patient is a candidate for CPAP, definitely we will encourage the patient to go for CPAP. Just because you are a surgeon, we don't advise surgery as a treatment option for a obstructive sleep apnea patient. So you have phase 1 surgeries, which are mainly the content surgeries. And then you have phase 2 surgeries, which are the box surgeries. So we'll see one by one. So the nasal procedures. So as you might know, the nasal breathing is very, very important for sleep quality. Nose block creates an increased airway resistance, which leads to downstream airway inspiratory collapse. So nose block also leads on to mouth breathing, which pushes the tongue posteriorly, which leads on to decrease in the space available in the oropharynx. So septal deviation, inferior turbinate hypertrophy, nasal valve collapse, polyps are few reasons why some patient can have nasal block, and these things are addressed appropriately. So oropharyngeal surgeries, the oropharynx is the commonest site of collapse of obstructive sleep apnea patient. So if you ask snoring and if you ask anybody, any doctor, what do you know about surgery for obstructive sleep apnea, they'll say UPPP, uvulo-palatopharyngoplasty. Let me make one thing very clear. Traditional UPPP is no longer done by anywhere in the world. So many variations of palatal procedures tailor-made for the specific type of palatal collapse are done these days. So, and these palatal surgeries are also done to facilitate upper airway stimulation therapy, which we'll see in the upcoming slides. So then you have tongue-based procedures. So untreated retrolingual collapse is the major reason for surgical failures. Previously, people used to refrain from doing tongue-based procedures because it used to be a complicated procedure and it can lead on to bleeding sometimes, which can be very difficult to control. But now we have very good visualization tool and hemostatic tools, so like ablation and transoral robotic surgery. So increasingly, we have started to do this retrolingual collapse surgeries, which definitely improves the surgical result. So then you have tongue muscle strengthening procedures. So genioglossus is a powerful dilator of the upper airway. So advancement of the genial tubercle, like this as shown in the, so you are advancing the genial tubercle, so which results in the strengthening of the genioglossal muscle, which results in the stable airway. So it is usually done in conjunction with the other phase 1 surgeries. So then this is a novel treatment which has started coming. It's still not being performed in our country, but it will soon come to our country as well. So upper airway stimulation therapy. So it is an electrode which is implanted in the medial branch of the hypoglossal nerve. It delivers unilateral respiration synchronized stimulation of the genioglossus and geniohyoid muscles. It results in the stiffening and protrusion of tongue, which results in airway opening. So this is the medial division of the hypoglossal nerve. The electrodes are inserted, and this electrode will deliver an impulse during inspiration, and this will result in stiffening of the tongue, and it will improve the airway for the patient. So then comes the phase 2 surgeries, which is total airway remodeling. So here we perform osteotomies on the mandible and as well as maxilla. We are pushing the mandible and the maxilla anteriorly, thereby increasing the space of the oropharynx. So it remains the most effective surgical procedure for obstructive sleep apnea, which can give results which are comparable to CPAP. So osteotomies, like I said, will be performed. So it results in more space for intraoral soft tissues and dilator muscle stability. So finally, bariatric surgery, weight and sleep apnea are directly proportional to each other. BMI above 32 leads to poor results with both upper airway surgery and CPAP. So correction of obesity with bariatric surgery will optimize the result in these patients. So finally, we'll come to the take-home message. So increasing understanding of pathophysiology of obstructive sleep apnea has resulted in accurate evaluation and customization of the surgical treatment. So proper surgical management can result in a socially acceptable and sustainable relief for obstructive sleep apnea. So weight management is a crucial component of management of OSA of any type and severity. So combining contemporary upper airway surgery with tools to modulate arousal threshold, loop gain, and muscle tone will define the future of obstructive sleep apnea therapy. And finally, I would like to use this opportunity to thank Tambaram IMA and the AMS for giving me this opportunity to present in this forum. Thank you very much again.
Thank you, Dr. Shaktish. There are many questions for you from Dr. Ashwin. Can MRI replace your DICE procedure for assessing the upper airway obstruction? Can MRI replace?
I don't think so, sir. From a practical point of view, it might be possible in an institutional setup, but practically, I have tried this dynamic MRI during the early years of my practice. Number one is the radiologist should be oriented towards interpretation of this obstructive sleep apnea related reporting. So we cannot be going and reporting every other patient. So the radiologist needs to be oriented, and in the most radiologic centers are very busy. It's a time consuming procedure. And another practical benefit of doing this drug induced sleep endoscopy is that you are going to be the treating doctor. You are doing a drug induced sleep endoscopy. You see what is going on. That is way much simpler than depending on somebody else to report and depending upon the accuracy of the report.
Another question is, how do you manage globus symptoms following UPP procedure?
See, once again, the current concept is to be very minimally invasive. So your globus sensation usually comes because you remove a chunk of the uvula. And when you do a very radical surgery with the palate, you get the globus sensation. When we do a targeted treatment, depending upon the type of the collapse, the globus is not practically a very big problem these days.
Thank you, Dr. Shaktish. A very good lecture. Even physician can understand the surgical procedures of sleep apnea syndrome. How many percentage are surgically treatable? The total sleep apnea syndrome, surgically treatable accounts for how many percentage?
Sir, actually, surgery as it is doesn't have any contraindications, sir. So there are certain patients who cannot be prescribed CPAP, but most patients, they can treated either by CPAP or surgery. So it is mainly the patient preference and the motivation of the patient whether he is prepared to use the CPAP on a long-term basis. That is the determining factor.
The surgery is if it is indicated only, not in all sleep apnea syndrome cases.
No, sir. See, the concept is, the CPAP is the gold standard of treatment. So we offer surgery only as an alternative for patients who are not willing for social reasons and they have compliance issue with CPAP. Only in patients like who have a gross tongue-based collapse and epiglottis collapse, they have to be managed surgically. Apart from that, if the patient is motivated to use CPAP, definitely CPAP would be my first advice.
So another question is, short neck are more prone for OSA? Is it
yes,
true?
sir. Those craniofacial abnormalities patients will do with you can directly proceed to phase 2 surgeries. The craniofacial surgeries will benefit those kind of patients.
Thank you.
Thank you, sir. Thank you.
I thank all the speakers for an excellent lecture. I think the audience would have been benefited very much. Thank you, one and all.
Thank you, Dr. Shankar Narayan. I hope you remember Chengalpet times.
I do remember.
You and Dr. Nirmal Frederick were there.
Yes.
When we did the street play.
Yes, madam.
I thank Dr. Shaktish and Hariharan for remembering those days and acknowledging.
Yes, ma'am.
Thank you, ma'am. Thank you.
Thank you.
With that lively presentation from Dr. Shaktish, we come to the end of session 2. I request Dr. Sri Priya to take over the session. We'll be moving on to session 3 now.
Thank you.
I thank you so much, LSN sir.
Thank you.
Thank you, Eril. Very good evening to you all. I welcome you all for yet another interesting session of today's meeting. We have two interesting, also important topics on sleep disorder, followed by panel discussion by group of experts. In the first part of the session, we have presentation on sleep disorder in children by Dr. Sheetal, followed by sleep disorder in women by Dr. Aruna. We have here Dr. V. Padma as chairperson for this session.
Good afternoon, everybody. Good evening. I welcome you all for the session, and I thank IMA Tamilnadu for giving me this opportunity. It's been a great day having lots and lots of inputs on sleep apnea. So sleep, and that is insomnia. So now we have two very interesting special situations. One is insomnia in children and insomnia in women. And this is something which every family is facing. And we have the sleep disorders, insomnia in children by sheet doctors. Problems they have: impulsive behavior, mood problems, memory disturbances, performance disturbances. Because of lack of sleep, using cell phone for a long time, they tend to develop problems of not able to concentrate in their work, and the performance gets affected. So we'd like to learn more about the insomnia in children from Dr. Sheetal.
Before we start with the presentation, I would like to introduce Dr. Padma and Dr. Sheetal. Dr. Padma is a professor of medicine at Sri Balaji Medical College, Chennai. She did her MBBS at MMC, Madras Medical College, MD, Kilpack Medical College. She has acquired PG diploma in diabetology and also fellowships including FRCP and FACP. Ma'am has published 66 papers in various journals, and she has also published 50 papers in various national and international conferences. There are 5 ongoing research programs under her guidance. She has also authored chapters in 8 textbooks. She's also a member of various national and international organizations. We are very happy to have you here, ma'am.
Thank you, ma'am.
The next topic we have on sleep disorder in children by Dr. Sheetal. Dr. Sheetal is an associate professor at Karpaga Vinayaka Medical College. She is a consultant at Sri Ranga Hospital, JSP Hospital, Sai Hospital, Chengalpat. She did her MBBS at Kempegowda Institute of Medical Sciences and MS at Sri Devraj Medical College. She has been trained in allergy and immunotherapy from Vallabhai Patel Chest Institute, New Delhi. Dr. Sheetal has won gold medal in her MS ENT examination. She has also published many papers in Indian and international journals. Welcome, Dr. Sheetal. Over to you.
Please unmute yourself, ma'am. Please unmute yourself.
Thank you, Shri Priya madam. At the outset, I would like to thank IMA Tamilnadu and AMS for providing me this great opportunity to present with these eminent speakers. I would like to start my topic. Sir, is the screen visible, sir? Madam, is the screen visible?
Yes, Dr. Sheetal. It's visible. You can start the slideshow.
Yes. So my topic is today's sleep disorders in children. Now, children's sleep differs from adult. Now, it is seen that there are more frequent REM and earlier REM in children compared to that in adults. And the total number of hours of sleep in children is comparatively more compared to the adults. And it is also seen that the sleep disorders are much more common in pediatric age group than in adults. Now, if a typical sleep hours, if you see, it has already been discussed in the first presentation by sir, where newborns sleep more than 18 to 22 hours. So they don't have this dicycle or diurnal variations in them. And as and when they are actually growing, their sleep hours also decreases. So by the age of 12 to 18 years, the sleep hours may reduce up to 8 to 9 years only. Now, when do you consider that these children are known to have sleep problems? Snoring, repeated awakenings in the night, restless sleeps, bedwetting, insomnia, daytime sleepiness, inattentions, irritability, lack in learning problems, depressions, and anxiety. Now, the sleep in these children can be seen in different types, either because of difficulty in initiation of the sleep, or the sleep gets fragmented or disrupted. Or in other way, the circadian rhythm get disturbed in these kids and they have an excessive, that is hypersomnolence can be seen. Now, this has already been said by Dr. Natarajan sir. What is the difference between a dysomnias and parasomnias? In dysomnias, the sleep quality may be normal, whereas in parasomnias, there will be an abnormal event such as screams, frightening dreams, and other things which occurs, but the quality of the sleep is normal. In dysomnias, they have difficulty in initiation of the sleep or maintenance of the sleep, or fragmentation is usually affected. So in this group, we can see primary insomnias, that is behavioral disorders in children, breath-related disorders like OSS, which is being previously covered by Shakti sir, narcolepsies, and certain movement disorders too. Now, who are the children who are more risk for sleep-related problems? Children with Down syndrome, craniofacial anomalies, people with cerebral palsies, muscular dystrophies, very obese children, autism, and ADHDs are also known to have high sleep problems. Now, what are the effects of these sleep problems on them? They all affect the cognitive, emotional, and physical well-being of the child. And if at all it is left untreated, it might affect the serious and also the CNS system, as well as the systemic complaints like hypertension and diabetes at a later stage. MI, rheumatic, right heart failures, cor pulmonale can also be result if they are left untreated. Now, in children, you have different varieties of sleep disorders that can be seen. The most common and routinely seen is behavioral insomnia of child. And sometimes, and in adolescent groups, delayed sleep phase syndrome is seen. A common type of sleep disorder that is seen in adolescents is inadequate sleep, insufficient sleep, and another variety of disorders of sleeps can be OSS. And disorders of arousals like nightmares, night terrors, sleepwalking, and also movement disorders. Now, coming to insomnias, this a definition of an insomnia is if the child has difficulty in initiating the sleep for 3 nights per week, or at least 3 months, and these are not related to any substance or any medical or any mental disorders. Now, the sleep disorder or insomnias are prevalent in about 1 to 6% of the pediatric age groups we see. What is this behavioral insomnia of childhood? This is the most commonest type of sleep disorders you see in children, and it is around 10 to 30% prevalence rates have been seen. Now, children usually have a resistance when they're going to the sleep, or they might also present with repeated night awakenings or night walkings. Very common in the 6 months to 3 years of the age group, toddlers and preschools. Now, in this varieties, you have 3 different varieties. That is sleep onset association, wherein the children or infants, they have trouble in going to the sleep. Usually they require a type of associations like nursing or cuddling or rocking the child before going to the sleep. In case if it is stopped, then they again come back, or repeated awakenings may be a problem for them. In limit setting type, usually this is more common in a toddlers or a preschool children, where bed stallings are very common, wherein they say that they don't want to go to the bed, or they repeatedly pester the parents to sleep along with them. And in a combined variety, you see both the types, where they need some association as well as they need something to the parents also to be there along with them to sleep. Now, this is what I wanted to tell: a sleep onset, maintenance, and sleep offset or non-restorative type of the sleep. So these are all the different variants of behavioral sleep disorders. Now, in adolescent groups, you see this variety wherein insufficient or inadequate sleep. This is very common in high school going kids, wherein because of their day-to-day activities, like too much of homeworks, or their routine or extracurricular activities, or use of phone, their sleep. So as a result, the school performances will usually come down. They become more irritable, daytime sleepiness, or more going to school and sleeping, and sometimes accidents are also more common in them. There's one more variety wherein you see a delayed sleep phase syndrome. This is a type of circadian rhythm disorder wherein the sleep cycle, awake cycle, is delayed by 2 hours or more. For example, instead of sleeping at 10 or 11 o'clock, they'll not get the sleep until 1 or 2 o'clock. So the sleep cycle is usually shifted to a 2 hours or more delayed hours. So this becomes very significant, persistent, intractable phase shift wake schedules are seen. So they do not get to the sleep until this desired time of sleeping is reached for them. Now, how do you treat this kind of disorders? You have to counsel the child or ask them to maintain a sleep wake schedule, shifting it more early, or maintaining a new sleep schedule. And there is a treatment where they do it something like phase development or chronotherapy, wherein ask the child to go to sleep 15 to 30 minutes earlier to the desired sleep times. For example, if they're sleeping at 2 o'clock in the night, ask them to slightly shift by 15 minutes every day and keep increasing, advancing the times by 15 minutes until a routine around 8 hours of sleep is usually gone. And make sure wherever they're sleeping, the exposure to the light during the night time should be reduced, and early mornings they're more exposed to the sun. And oral melatonin or melatonin agonists have also been tried in these disorders. Now, this topic has been in depth described by Dr. Shakti sir. So I'll just brush up with sleep disorder breathing. In sleep disorder breathing, you have two varieties: a simple snoring and obstructive sleep apnea. So children around 3 to 12% are known to have a simple snoring without any breathing related disorders. Whereas in OSAs, where central, obstructive, and mixed varieties, this is also been discussed in the previous presentation. So OSAs incidences is seen in around 1 to 3%. As a result of OSAs, and episodes of apnea and hypoapneic indexes are actually increased. So this results in systemic and pulmonary arterial pressures increases, and risk of cardiovascular and CNS related problems are more. So this causes have also been discussed: nasal like DNS, adenoids, polyps, mucoceles. They can all cause obstruction resulting in the OSS. And oral cavities and laryngopharynx, especially in children, tonsils and adenoids are the most commonest one to come up with. Lingual tonsils and craniofacial abnormalities, maxillary hypoplasias, laryngoceles, valvular cysts are the other causes wherein children can present with OSS. Now, as a result of OSS, they can present with repeated arousals, and because of the apneic episodes, hypoxemia, hypercapnia, and acidemias may result in the systemic autonomic nervous system activations. Now, what are the implications, cognitive complications of these OSAs? The children are usually irritable, lack of concentration is inadequate, poor school performances, hyperactivity disorders. They also may have developmental delay and aggressive behaviors and social withdrawals in them. Now, management has also been completely dealt in the previous slide, where the most important testing what we do is PSGs, DIAS, and sleep endoscopies. So in case we have to identify whether they are just a simple snorers or it is an obstructive type of OSS. So risk factors and complications also need to be ruled out in them. In case of clear-cut obstructive type or surgical options, 70% of the cases adenotonsillectomy shows an elevation of the symptoms, and it has been noted that with tonsillectomy and adenoidectomy alone, children with OSAs have a better outcomes and improvement in the school performances. And in those cases, children's using CPAP and BiPAP is very, very difficult. So surgical options are better in children rather than giving the CPAP and BiPAP, because poor compliances in them is a major risk factor with these. Now, another type of sleep disorder is narcolepsy. This is a type of neurological disorder where they're associated with excessive daytime sleepiness. So it is characterized by cataplexy, wherein there is a sudden motor loss to a strong emotional stimuli, and hypnagogic hallucinations. That means the kids might have certain vivid dreams during the early phases of the sleep. They might go for sleep paralysis and also autonomic behaviors. So how do you identify or diagnose these narcolepsies? Simple PSGs may not be sufficient in these cases. You need to do a multiple sleep latency test, and usually this affects the early REM. So you need to educate the child, bring in good sleep hygiene, pharmacological interventions such as modafinils and atomoxetine, and anticholinergic drugs like clomipramine and imipramine have been tried. So especially for narcolepsies, these drugs have been showed some kind of improvements, but more than that, scheduling the sleep for regular hours, a correct wake up time and a sleep time has to be appropriate to these kids. And coming to the disorders of arousals, where parasomnias, in this, sir has already Natarajan sir has already discussed about this. So there are different types of events that can occur during a normal sleep, such as sleep terrors, sleep talking, sleepwalking, and confusional arousals. Now, these parasomnias are more likely to affect the REM sleep, NREM sleep, except the nightmares, which can affect only in the REM sleep. So, what is nightmares? They are characterized by sudden and a high arousal, and the child seems to be highly terrified. Very common in 3 to 6 years of the age, and nightmares are one which are commonly affected in REM type of sleep. Children usually believe these dreams to be very real. Whereas in night terrors, this affects mainly the stage 3 or stage 4 of NREM sleep, and they are associated with autonomic symptoms too. They seem to be frightened, scream, and confused. Some of the triggering factors for these things includes inadequate sleep, disruption, altered sleep schedules. So the differences between the nightmares and night terrors are, this is more in REM sleep and this is NREM sleep. They're more likely to occur in the late nights, that is early mornings, and this is in the early in the night. Treatment of parasomnias is sleep hygiene, regularizing the sleep schedule, and treatment with benzodiazepine and tricyclic antidepressants, and a safe environment, educating the parents as well as the child how to react at the time of events. And there are some things called movement disorders like restless leg syndrome and periodic limb disorders. This is a type of uncomfortable sensations which occurs in the legs more in the evenings and long periods. And periodic limb
Hello. Dr. Sheetal, hello.
I think she's not there.
Yeah, I think she lost signal.
Yeah.
I'll just call her, and if
Yeah.
not, we'll move on to the next.
Yeah, it was at the end of it.
Yeah.
We can ask the question answers if it is there after the second session.
Yeah.
You can call the next speaker.
Yeah.
So if she joins, she can add her inputs before the panel discussion.
Yeah, I think we can start with the next speaker, sir.
Yeah. I request Dr. Sripriya to call the next speaker.
Thank you, Dr. Sheetal. That was very informative. The next topic is on sleep disorder in women by Dr. Aruna Shanmuganathan. Dr. Aruna ma'am is a professor at Department of Pulmonology, Karpaga Vinayaka Institute of Medical Sciences, Maduranthakam. She has also worked as professor in Chettinad Hospital, Savita Medical College, Meenakshi Medical College and Hospital, and Sri Ramachandra Medical College. She is also a consultant in Apollo Hospital, Ainambattam. She did her MBBS at Bangalore Medical College and MD Institute of Thoracic Medicine, Madras Medical College. also DNB from Madras Medical College. Ma'am has published a lot of papers. She has been speaker in various state and national conferences. She is a postgraduate examiner and guide for UG and PG dissertations and papers. Ma'am is also a member of Indian Medical Association, Indian Academy of Allergy, American Thoracic Society, European Respiratory Society, Association of Pulmonologists in Tamil Nadu and Pondicherry. Welcome, ma'am. Over to you.
Thank you, Dr. Shripriya, for those kind words of introduction. And since it's the last session of the day, I hope the speakers and the audience will continue to have the same enthusiasm as the previous talks. And please give me a few seconds to share my screen. Yeah. Is my screen visible and am I audible?
Yes, ma'am.
Okay, sure. Thank you. And at the outset, I would like to thank the IMA team for giving me an opportunity to be a part of this wonderful session on sleep. And I would also congratulate the organizers on selecting the subtopics of the session, which are which have been, I think, a great source of utility for the audience. So let me just move on, and in the next 15 minutes or so, I would be covering the important differences as to how sleep differs between men and women, and what is the prevalence of the common sleep disorders in women, and how do we approach women when they come with sleep complaints. It may be either insomnia or any of the sleep complaints, and what is the impact of sleep on women regarding the hormonal factors, regarding circadian rhythm and various endocrine factors, because women undergo major hormonal transitions at their during their entire lifespan, as I talk shortly. Let's then look at the common sleep disorders in women and the management. And what I would like to say is, I think the foundation is already very strong. It has been laid by the previous speakers regarding the diagnosis, and the pharmacological, non-pharmacological management has been covered extensively and elaborately. So I would just look at the issues specific to women, and finally the salient take-home messages. So how does sleep differ in men and women? So sleep complaints as such are almost twice as common in women. But however, sadly, there is a gross underdiagnosis of sleep disorders, because women tend to perceive their symptoms of sleep very differently from men. And also they have certain atypical symptoms. So we have to really identify these symptoms and diagnose sleep issues in women initially, so that we can offer them the correct treatment options. And several studies have shown that there are very important sleep-related biological differences that exist between both the genders. And unfortunately, most of the research which is done in sleep medicine, whether it is for treatment or for whether for diagnosis, is mostly done in men. So whether we can just extrapolate these results to women is still something that we have to think about. The other important thing, as I had said earlier, is the reproductive hormones and the sex hormones and the gonadotropic hormones, as well as circadian rhythms and endocrine factors, have a major role to play in the development of sleep disorders in a women's life cycle. And these the sleep differences actually start emerging during puberty. So till puberty, there's no major difference in the prevalence of sleep disorders or in the way they present between both the genders. However, from puberty onwards, through the menstrual cycle, the premenopausal phase, when you have pregnancy and menopause. So these are important phases in a woman's life cycle, where we really, where certain sleep disorders, start becoming prevalent, or which were pre-existing start getting exacerbated. And of course, the most common sleep disorders we encounter in women in practice are the insomnias, then we have the restless leg syndrome, then we have obstructive sleep apnea, some of the parasomnias, and the circadian rhythm sleep disorders. And though women usually, it's quite surprising to note that though they sleep slightly longer than men, however, the quality is quite low. And because they have other additional responsibilities like caretaker responsibilities, family and societal responsibilities, which women have to go through. So, in general, though the recommended sleep for the men and women is the same. So there is no difference in recommendation between the amount of sleep for men and women. It's around 7 to 9 hours of sleep. And it's quite sad again that hardly around 2/3 of women actually get that amount of sleep. So it's not only the amount of sleep, it is the quality of the sleep also, which is very, very important. And women generally, they have a longer sleep latency. That is, they take a longer time to fall asleep. However, women spend more time in the slow wave sleep, which is more restorative for them. And as they grow older, increasing age, okay, is associated with more of excessive daytime sleepiness, and the sleep quality and fragmentation issues start to emerge as women age. As I said earlier, the major changes in women in sleep quality or the quantity start emerging at puberty. So let's just rush through the prevalence of the common sleep disorders in women. So insomnia is the most common disorder and is almost 40% more prevalent, and 40% of women are more likely to have insomnia symptoms. And the risk factors for insomnia increase with age and menopause and of course pregnancy. And regarding the prevalence of the next important sleep disorder, that is obstructive sleep apnea and excessive daytime sleepiness, there is a wide range of prevalence. See, you can see it is almost, there is a 7.8 to 77%. So why is there such a huge difference in the reported prevalence of OSA across several studies or trials? Okay, so this is because there is a difference in the the diagnosis of OSA. The diagnostic criteria vary from country to country and between studies. And in India, we have a prevalence of around 5.4%, with of course a 2 to 3-fold higher prevalence in men. But as I'll tell you shortly, as women age, so as we age, the difference in prevalence between the genders decreases. So that's a very important fact to note, that especially as women approach menopause, in the perimenopausal and postmenopausal phases, the prevalence of OSA dramatically increases. And of course, pregnancy is another controversial subject with OSA, because though pregnant women do report higher episodes of snoring and choking and apneic episodes, the actual prevalence is controversial, and we'll talk about it in the subsequent slides. So the next important disease that we have to know the prevalence in women especially is the RLS, or the restless leg syndrome. And in women, it is especially common to note RLS. The prevalence is higher in pregnancy and menopause, and almost 80% of the restless leg syndrome patients have the periodic nocturnal, the periodic limb movements are also associated. So if you just look at the prevalence, this is just a slide to show you that as the age increases, so the gender differences in the prevalence of OSA are narrowed down. So with age, the prevalence of, though there is a wide difference in the prevalence of OSA in younger men and women, that is, men are 2 to 3 times more likely to develop OSA or suffer from OSA. Women, as we grow older, the gender differences become smaller. So how do we approach patients, female patients who come with sleep complaints? So this is very important, because as primary care providers, it's very important to take if not a very elaborate history, certain very important points in the sleep history have to be noted. And it's the first thing is, of course, the age of the patient, because as I said earlier, major hormonal transmissions happen throughout the lifespan of women. So if the child, is she in the adolescent phase, has she attained puberty, or has she just crossed over puberty, and is she having a lot of menstrual cycle related problems? Okay, that is one. Then you come to the pregnancy. So is she in the first, second, third trimester, because each trimester has its own specific sleep related issues. And then of course menopause and its associated issues. So the age of the patient and determines the actual hormonal level at which the woman is in her lifespan. Next important thing is to ask about the sleep hygiene. So it's very important to take a detailed history regarding bedtime, awakening timings. It's not only the amount of time the woman spends to sleep, but it's also the quality. What are certain weekend patterns, say, especially working women or those in shift work timings? So they tend to oversleep in the weekend. Or you see adolescents, they just have sleepover patterns, sleeping patterns which are abnormally, very abnormal in the weekends. So it's very important to get the weekend history also. And also, the type of symptoms and the perception of the sleep symptoms in women is also very important. Majority of women complain of insomnia as a primary complaint, but however, insomnia may not be the primary complaint, and insomnia
Excuse me, audio is not clear. Audio is not clear.
Sorry, madam. Yeah. Is it okay, madam? Now, are you able to hear me a little better?
Voice is still breaking, ma'am.
Probably a signal issue. I think it's a signal issue.
It's some network issues, I guess. I'm sorry for the network issues. Okay. Yeah. So I'll just go ahead, and we also have to ask the history regarding the lifestyle of the women. So, physical activity. What is their diet? Are they obese? Okay. And so these are very, very important, especially in the diagnosis of OSA. So many women who actually suffer from OSA do not complain of epic episodes or choking. And because usually, even in men who have OSA, it's usually the wives who complain that my husband snores. But unfortunately, the vice versa is not true, because I don't think husbands are even aware that their bed partner snore or their spouse snores. So it's very, very important that the perception of symptoms and the underreporting of symptoms often leads to an underdiagnosis of obstructive sleep apnea in women. As I mentioned earlier, shift work women. So this is a very, very important thing, especially women who are whose professions are related to healthcare, or who are working in the airline industries. So these women generally, they have a very poor quality of sleep because they're not able to catch up on their sleep when they go back after work, due to so many responsibilities on the family and the caretaking side. The next important history when we are eliciting a sleep history is a medication history, because we have a host of medicines which precipitate or which are associated with sleep disorders. Like we have antidepressants, a lot of patients, women may be on antidepressants for a long time, opiates, and over-the-counter cold remedies also. So there is a great propensity, especially in our country, to get medicines, whatever you want. Most of them are available over the counter. So these also interfere with the sleep in women. Also, substance abuse regarding alcohol, smoking. And I think we have crossed the barrier where we, earlier we never used to ask women about all smoking, nicotine or alcohol. But now it's become a fad and a fashion. So substance abuse history is very important in a sleep history. And of course, personal issues. So it is a very important role of a physician to be to have a bonding with the patient, so that they open up and come up with their familial or emotional issues. So these may be relatively simple to tackle if we can understand these issues. So coming to the impact of hormonal factors on sleep. So as I've just shown you in the menstrual cycle, we see that the estrogen and progesterone levels vary across the menstrual cycle as compared to in the follicular phase. We see that the estrogen levels peak, and after ovulation, what happens is progesterone peaks in the mid-luteal phase and then falls gradually towards the late luteal phase. So because of these hormonal changes during puberty, there is an increase in the daytime sleepiness. Hypersomnia is reported, but of course, sleep disordered breathing is not very common because of the protective effect of the sex hormones. Estrogen generally decreases the sleep latency and is associated with fewer awakenings. And when in the late luteal phase, when the estrogen levels as well as the progesterone levels drop, there is an associated sleep fragmentation. Now, progesterone as a hormone, if you see, is a GABA aminobutyric acid agonist, and it's a thermogenic hormone. And that is why when the progesterone levels drop in the late luteal phase, most of the sleep disturbances are seen. And of course, sleep changes during the menstrual cycle, especially adolescent girls who are in their early menarche, who have premenstrual symptoms. who have premenstrual symptoms often have bloating and crampy sensations. So this also contributes to a lot of insomnia in this age group. And of course, the next important phase in a woman's life is pregnancy. So pregnancy, apart from hormonal fluctuations, we have various physical factors. In the first trimester, nausea, vomiting, increased frequency of micturition, GERD and heartburn, and back pain. These are certain issues that can contribute to insomnia. And if you look at the certain physiological changes that happen during pregnancy because of the increase in the progesterone levels, the minute ventilation increases, and as the pregnancy advances through the third trimester, because of the gestational weight gain and the functional residual capacity of the lungs also decrease. So it's associated with increasing arousals from sleep. And also of course there are certain factors that protect the sleep, like lying on the lateral posture, and a decreased REM sleep time also decreases the frequency of REM disorders in pregnancy. So in the third trimester, especially snoring episodes, OSA, restless leg syndrome, these contribute to the sleep disorder breathing in pregnancy. I'll just take a few more minutes, sir, because there were some problems in the connectivity. During menopause, what I want to stress is there are great hormonal transitions that happen, and there is a drastic drop in the estrogen levels and increased LH hormones. So because of which there are a lot of sleep fragmentation and excessive daytime sleepiness happens. And in pregnancy, in the postmenopausal phase, there are a lot of vasomotor symptoms and hot flashes that also contribute to disturbed sleep in the menopause period. Circadian rhythm is a very, very important factor that we have to keep in mind, and women are more prone to the sleep-wake disturbances which happen. So, and circadian rhythms are in every cell has its own circadian rhythm. And of course, we know that the master biological clock is in the suprachiasmatic nucleus in the hypothalamus. And melatonin, the important hormones that show a great circadian rhythm variation are the melatonin, prolactin, TSH and cortisol. So as the effect of the morning, the daytime and the night has a great impact on the secretion of melatonin. Another important endocrine factor is has a very important role to play in the polycystic ovary syndrome. So this actually is a metabolic syndrome, basically because of a hyper androgenic state, and women with PCOS often have an insulin resistance, which is a background. And because of this metabolic component and insulin resistance, they are more prone for developing sleep disturbance, especially OSA. And this is a bidirectional pathway. Women tend to have an abnormal distribution of fat, obesity, and depression and anxiety is common. This in turn leads to a bidirectional influence on sleep with polycystic ovarian disease. Of course, gender factors in women are well known. More of responsibilities on the family and socio-cultural issues. And this I have already said. So let's just talk about the important sleep disorders in women, especially insomnia. So the diagnosis of insomnia, the diagnostic criteria have already been dealt with. And we know that insomnia can be either primary or secondary. And it's very important to remember that around 20 to 30% of women with insomnia have depression as a primary a problem. And insomnia is a very important atypical symptom of obstructive sleep apnea, which we have to recognize. And the hormonal factors I've already discussed. In adolescence, they may be related to the menstrual cycle and a severe form of the premenstrual syndrome, which I'll be talking about. Pregnancy, especially the first and the third trimesters. And it's very important to note that insomnia worsens as women age. And chronic pain conditions in women are very common, like fibromyalgia, migraine, and arthritis. And I'm not talking about the management because this has been extensively covered in by the previous speakers, both the cognitive behavioral therapy as well as pharmacological and non-pharmacological therapies. Obstructive sleep apnea, I would just like to say that as women age, especially in pregnancy and in the post-menopausal phase, it's very important to diagnose OSA because of several hormonal factors and metabolic factors. And there's a very controversial role on the hormone replacement therapy, because certain studies have shown that though hormone replacement therapy has improved the subjective sleep quality, the risk-benefit ratio has to be considered. And hence, as a recommendation, hormonal replace HRT is not routinely recommended for the treatment of OSA, and CPAP remains as the gold standard of treatment. Next, we look at RLS, that is the Willis-Egborn disease. And restless leg syndrome is, of course, an uncontrollable urge to move the limbs. And typically, it is associated with a crawly, creeping sensation in the lower limbs, and it is relieved by activity. It is the important thing I want to stress about the RLS is the dopamine iron hypothesis, because it has been shown that iron deficiency anemia is a very important factor associated with restless leg syndrome, especially in pregnancy. And iron is an important cofactor, is a rate for dopamine synthesis. So this is what I want to stress. And 80% of RLS have periodic limb movements. And the treatment of RLS, of course, is pharmacological and non-pharmacological. So it's very important to recognize whether the RLS is a primary disease, because there are a host of conditions which are associated with RLS. Like, as I said, iron deficiency anemia, it may be medical diseases like CKD or liver failure or substance abuses, and various drugs like lithium and which may worsen the RLS. Parasomnias, as has already been mentioned about, are certain unpleasant physical experiences. And the two important female predominant parasomnias, which I'd like to stress on, are the nocturnal sleep eating disorders, which usually we see in the late teens. This is usually a part of a sleepwalking disorder, wherein women sleepwalk and then they binge eat in the night. So this is a very common disorder, the female predominant parasomnias. Other parasomnias, of course, are mostly male predominant, like the REM sleep behavior disorders. But women often become a victim to REM sleep behavior disorders in men, because they may get physically abused when their pet partner is having a REM disorder. So next, let's a few slides on circadian rhythm abnormalities. So the delayed sleep phase syndrome in adults is mainly in the teenagers. And this is especially due to a circadian rhythm. We generally think that teenage girls, because of societal pressures or due to social peer pressures, they tend to have a late night sleeping pattern, and they often awake at just for lunch. But unfortunately, so it's very important to recognize that there is a delayed release of melatonin because of some homeostatic dysregulation that happens in adolescence. The other important one is a severe form of PMS, that is the premenstrual dysmorphic disorder, which is also a circadian disorder. It's basically a mood disorder and is also typically symptoms start during the late luteal phase. It's associated with a lot of mood disorders, and the therapy is, of course, pharmacological, light therapy, and sleep deprivation. So basically, RLS is also one of the disorders that is commonly seen in pregnancy and in the postmenopause, is a circadian rhythm disorder and shift work sleep timings. So the basic treatment of any circadian rhythm sleep disorder is a phototherapy, chronotherapy, a chronobiology for sleep hygiene, and several pharmacological and non-pharmacological interventions. So the treatment consideration, how does treatment differ in men and women as compared to sleep? So women are at risk for a lot of adverse effects. So when we prescribe drugs, we have to note that whether the woman is of a childbearing age. Is she on oral contraceptives? Because there are several drug interactions which are there, and there are several class C drugs which are to be avoided in pregnancy, which I have mentioned. I know due to lack of time, I'm not reading them out. Also, when the women are lactating, it's very important to prescribe, to note what you're prescribing. And a special drug is zolpidem, which we commonly prescribe. And it has been proven that women metabolize zolpidem much slower, and they require just 50% of the dosage of zolpidem. So there are, of course, gender-specific changes in certain drugs which we have to keep in mind. It's also interesting to note that women require lower CPAP pressures for the same severity of OSA as men. So this has also something to ponder about. So just to conclude and take home, it's very important to recognize sleep disorders in women, because they're much more prevalent as we compared to what we previously thought of. And insomnia is the most common sleep disorder, followed by obstructive sleep apnea, especially as women age and in the postmenopausal phase. We have to look out for the premenstrual dysmorphic disorders in adolescents, and the management is basically an early identification and give a gender-specific recommendation. And this enables better quality of life to the women in terms of physical, emotional, and the functional well-being of women. So thank you for the opportunity, and these are my references. Thank you.
Yeah, thank you, ma'am. Thank you so much for an excellent and an exhaustive presentation on insomnia in women. I think you have answered whatever question is there in the chat box. The questions were on the use of hormone replacement therapy, whether it will be useful in OSA patient. And I think you have answered already about that in the lecture. Is Sheetal ma'am there already? Because there are a few questions for Sheetal ma'am who, because of connectivity issues, had to leave.
Yes, I'm here, ma'am.
Yeah,
Yes, ma'am.
ma'am, there are two questions. One about the role of restless leg syndrome in children. And the next thing about the OSA in children. Any biomarkers are available? So these two questions are there for you.
As such, being an ENT surgeon, I am not sure about any biomarkers. We are mainly considering only on the type of the etiology which mainly causes the OSA. I have not gone across any kind of biomarkers that is there. And what in restless leg syndrome is the question?
Yeah, restless leg syndrome in children.
It usually children they experience a kind of creepy and a crawling sensation, and a type of uncomfortable sensation which occurs in the leg. And the more in the evening times, this syndrome is more common, and they get the symptoms get elevated when they're jumping or when they do certain movements and all. It reduces, they say. So commonly, there is no. They have been tried with benzodiazepines and dopaminergic drugs have also been tried in these children.
Okay. Thank you so much, ma'am. It's been an excellent and exhaustive session with dealing with both women and children. And thank you, Sheetal ma'am and Arna ma'am. And I thank IMA Tambaram for giving me this opportunity to chair the session. Thank you so much.
Thank you.
Thank you, Dr. Padma, Dr. Aruna, and Dr. Sheetal for making this session interesting and informative. Now we move on to the panel discussion on role of primary care physicians in sleep disorder. We have here 5 experts from various fields. Dr. V.S. Hariharan will be the moderator for this session. I now take few minutes to introduce the moderator and the panelists. Dr. V.S. Hariharan is a consultant at Global Health City, Sudan Hospital, Tambaram, H2 Clinic, Nirmal Eye Hospital. He did his MBBS at Chengalpattu Medical College, DMD at Sundram Medical Foundation, and MRCP UK. He is a speaker in various IMA forums and winter symposia. He is a member of Indian Medical Association, Royal College of Physicians, Edinburgh, and American College of Physicians. He has received the Best Doctor Award in 2004. Welcome, sir. On the panel, we have Dr. Padma Balaji, pediatric neurologist. She is a consultant in Rainbow Children's Hospital, Chennai. She did her MBBS and MD Pediatrics from MS University, Baroda. She has postdoctoral fellowship in pediatric neurology in 2012. Her fields of interest are sleep disorder in children, sleep-related issues in children with cerebral palsy, neuromuscular and neurodevelopmental disorders. Welcome, ma'am. We have Dr. Shaktish, otorhinolaryngologist. He's a consultant and director, Hopkins ENT Clinic, Chennai. He has worked as senior assistant professor in ENT, SRM Medical College and Research Institute. He did his MBBS at Chengalpattu Medical College and MS from Upgraded Institute of Otorhinolaryngology, Madras Medical College. He acquired fellowship in Philippine Society of Snoring and Obstructive Sleep Apnea. His special interests are in snoring and sleep-related breathing disorders and also in endoscopic ear surgery. Welcome, Dr. Shaktish. We have Dr. Pichumani. He is the Managing Director of Sri Ranga Hospital, Chengalpattu. He finished his graduation from Chengalpattu Medical College. He did his postgraduate diploma in diabetic care and master's in diabetic care from Newcastle University, Australia. He is also the founder of Chengalpattu Diabetic Care and Research Center in 2000. Welcome, Dr. Pichumani, sir. We have Dr. Jayaraman, sir, consultant pulmonologist, specialist in interventional pulmonology and sleep disordered breathing. Sir is a consultant at MGM Healthcare, Apollo Medical Center and Apollo First Med Hospitals, Bilroth Hospital, Sri Jayam Chest and Sleep Clinic, Chennai. Sir is the president of Indian Medical Association, Chennai Villivakam Ayanavaram branch. He is also a fellow of American College of Chest Physicians, member of Indian Sleep Disorder Association and Chest Society, also a member of Indian Association of Bronchology and Interventional Pulmonology. Sir has presented 15 papers in reputed journals and more than 150 papers in regional, national, and international conferences. Welcome, sir. We have Dr. Shiva Prakash Srinivasan. He's a consultant child, adolescent, and adult psychiatrist. He's currently working at the Schizophrenia Research Foundation. He did his MBBS at Madras Medical College and MD at All India Institute of Medical Sciences. He is a life member of Indian Psychiatric Society and Indian Association for Child and Adolescent Mental Health. Sir has published many papers, including papers on psychosis and schizophrenia, urban mental health. I welcome all the panelists and the moderator for this discussion. I now invite and request Dr. Hariharan sir to take over the panel discussion. Over to you, sir.
Thank you, Dr. Sripriya. So I think after a long discussion on sleep, we are going to sum up with the last few minutes on the role of primary care physician in sleep disorders, because I think this is the most important thing. Sleep disorders are the most least recognized disorders that have been there, and most of us just pass through it, just writing an alprazolam and pass through it without much going into detail. So I think we have a physician who's a primary care physician, we have a surgeon, we have a psychiatrist, we have a pediatrician and a neurologist, and a very senior pulmonologist in this panel. So since most of it has been discussed, I will just go through small questions, which will be a reminder for most of us to continue practicing it. So I think I'll start with Dr. Pichmani. I think, sleep disorders are not very often addressed. And as a primary care person who is doing a lot of primary care work, what do you think is the best way to improve diagnosing sleep related disorders in adults? So please unmute yourself.
Good evening, Dr. Hariharan, and warm welcome to all our colleagues on the panel. Of course, it's been a great pleasure to be invited to this particular session, and it's been an exhaustive session for the past 4.5 hours. The big deliberations have gone through. As rightly pointed out, the sleep disorders are actually being neglected in our population, and sometimes it's over-exaggerated by few individuals. Like as I've been practicing diabetology in this area for a long time, and of course I'm covering most of rural areas. I'm astonished to see so many patients with the sleep disorders. More than that, there are a lot of misconceptions about the sleep and the pattern of sleep and how they don't sleep at all during 6 months, 8 months, and so on. They used to complain. So that is really fascinating. Of course, definitely the more and more things we are addressed instead of just giving one alprazolam or one anxiolytics or hypnotic drugs to the patients. As far as primary practice is concerned. Of course, especially when the patients are 60 years and 70 years and above with the diabetes and so on, they are not only having some sleep problems, they're also having some physical ailments that also actually worsen their whole scenario. So I think the GPs have to really consider a lot and discuss about the problem with the patient and take a proper solution. I think this seminar would have definitely opened the eyes.
Thank you, Puchmani sir. I think we'll move the next question to Dr. Padma. How common are sleep disorders in children, and what are the most common problems you find?
And I must say, all the speakers have made my life very easy. And like as you said, pediatrics children, they do not come in with sleep problems, but rather during the course of our talk with them, we invariably find them talking about two things. One is food and sleep. So sleep issue is definitely a very predominant complaint amongst children. And like as we said, the sleep are more causing trouble in children. And of that, we have apnea, and in children it is main. And the other two things that I would like to highlight here, which is specifically unique for children, is one, in the early months of life, it is rather a parental misperception of the sleep physiology in the newborns and in early infants. Like as we said, newborns, they sleep for a longer time, the sleep phase is divided equally between day and night, and also we not have the ability to soothe themselves. So which means that once they arise from sleep, they cannot go back to sleep on their own. Normal circadian to self-soothe or go back to sleep during micro arousals comes maybe at around 12. And reassurance saying that sleep cycle will get established on their own. They will say that the baby stays awake during the night, sure, most of us, and usually it settles off. Of course, they can have problems related to GARD and feed intolerance, which can cause sleep disturbances in the early part of infancy. And the other most that I will say that comes up is in adults, sleep medicines usually cause insomnia, but
Ma'am, I think that
so I think that is another one that we have this described in the talk on this on the children. This is delayed sleep wait. Initially, it was only in the adolescent phase, but among the younger children also because of the excessive gadget use and don't cycle. So these are the ones which are most commonly seen in the pediatric age group. That's what I've seen.
Thank you, madam. I think we'll go back to Dr. Pichumani, sir. See, I think throughout the talks, we kept hearing good sleep improves diabetic control, good sleep improves blood pressure control, good sleep improves cardiovascular status of the person who's there. So, as a primary care physician, do you resort to drugs or non-pharmacological measures?
Once you get a detailed history from the patient, and also you spend some more time with the patient, definitely you can straight away clarify the doubts of the patients first. And many times actually we are introducing such medications which disturbs the sleep during nighttime. See, the problem is you give a diuretic for a patient during nighttime without the knowledge whether the patient has a good sleep or he's going for excessive diuresis during night. And also at the age of 60, 65, there's always a prostate problem creeping up. So we don't actually properly investigate and start giving medications with the proper investigations also. That's also a problem. The other side is drugs like glyphosate, where the SGLT inhibitors are there. They are very effective drugs, and of course, that causes diuresis on its own. And that is going to actually contribute more and more diuresis during the night, and that's also going to disturb the problem. So there is sleep disruption happening for all these patients because of our own iatrogenic causes. I would like the practitioners to concentrate on the iatrogenic causes of sleep disruptions in the older individuals, apart from the physiological and pathological ones that's occurring due to melatonin and so on. So it is very vital on the part of the doctors to prescribe properly and prudently with the caution. Of course, it's only a recent past 1 decade, the ADA, American Diabetic Association, recognized that sleep as a separate risk factor in the development of diabetes, which was not happening previously. So, and also there is also one more controversy. There are some papers even stating the excessive sleep also can produce a lot of problems, especially in hypertension. So that is also one more paper available. So all these, considering all these factors into consideration, as a general practitioner or persons practicing for a long time and having patients of 60 and 70 years of age treating, I think the prescription writing has to be very important. Polypharmacy is a big problem, and drug interaction needs to be considered a lot. The gastroparesis, GERD creeping up because of the autonomic neuropathy and so on. So you need to address all the issues properly. If all these issues are properly addressed, I think we can have a better quality of life for the patients. Thank you.
Thank you, sir. I think next question will go to Dr. Shiva. See, I remember days where after the 8:13 DD news, most of us used to go to sleep, right? And nowadays the night goes on and on to 12 o'clock and 1 o'clock. has this affected the general mental health of the adult population around this place?
Thank you, Dr. Hari, for bringing up this important point. This actually shows the huge age gap between us and the people that we are working with. So right now, more and more we have started seeing people who have been working through the night, or they work at UK times. So they work 5 hours later than the usual time. So they'll start work at 3 o'clock and at 10, 10:30, 11, and so on. So as you very rightly pointed that, and all the speakers before now have talked about the mental health impact. The important thing that I would want us all to recognize is we are not talking only about mental illnesses, but there are lower levels of problems also that we are seeing. The most common things that we can ask in terms of symptoms are changes in mood. So is there more irritability? Are there more crankiness when we talk about children? Are there changes in cognitive function? So is the child or the adult or the adolescent finding it difficult to stay focused on tasks? Do they tend to forget small trivial things like go to the shop, forget to buy eggs, go back to the shop and forget to buy eggs again? So things like that. And so we are not only talking about major mental health problems, but we are talking about significant symptoms which could potentially affect the day-to-day functioning of the individual. And this is definitely one of the huge contributors is, as we talked about at length, physiology prevents us to sleep beyond a particular time during the day. Right now, practically with adequate or lots of exposure to backlit items and to artificial lighting, we are able to push our sleep further and further later. And so it is really important for us to recognize that we may not be dealing with severe mental health problems in primary practice, but we would be dealing with lots of these chronic small things which will add up. So it's something for all of us to keep in mind.
Thank you, Shiva. I think that answered the question. We'll go to Jayaraman, sir. Sir, you as a pulmonologist, you see a lot of patients with bronchial asthma, COPD, maybe some associated heart conditions, and they suffer just not because of the insomnia part. They can't sleep in the night because of their respiratory problem. So how do you think you can help them improve sleep? This is something that most of the common general practitioners face every day.
Good evening. Thank you for this opportunity. First of all, thank you, AMS and Tamilnadu branch. Regarding the respiratory perspective, asthma, COPD, we're all commonly seeing day-to-day practice, very, very common disease. So we have to treat the basic disease with the proper medication. If asthma patient, we have to prescribe proper inhaler to control the disease. For COPD also, inhaled medications are the cornerstone treatment. So airway disease management, lower airway, the common disease we see is the asthma and COPD. We write a full-fledged prescription to control the disease. For whether asthma and COPD, whichever the disease, we prescribe correct medications to control the inflammatory basic disease, and reliever medications also we prescribe. So there is no sleep problem at all. But the asthma, COPD, the common association is the sleep apnea. This is one of the overlap common comorbid conditions we have to treat. Any uncontrolled asthma, one of the comorbid conditions we see is the sleep apnea. Overlap syndrome, commonly sleep apnea, OSA and the COPD is a common association. So each and every patient of respiratory disease, obesity, respiratory system, one of the common indication is sleep study and find out the obstructive sleep apnea. One of the common condition as a pulmonologist perspective. So sleep apnea is a very, very under-recognized condition from the primary care point of view, under-recognized, under-diagnosed, under-treated condition. So this aim of this topic today is one of the very good awareness we created. So primary care physician, whether sleep apnea or snoring disease or insomnia. Insomnia also one of the atypical symptom of the sleep apnea only. So any sleep issue, sleep apnea is one of the major malignant disease. So we have to treat effectively. Otherwise, it can lead to a lot of complications. You all know well, obstructive sleep apnea is one of the syndrome Z component. Syndrome Z, you all know well. Metabolic syndrome or syndrome X, there are 4 components: diabetes, hypertension, dyslipidemia, obesity, plus OSA. We call it a syndrome Z. Sleep apnea is a mother of modern epidemic diseases, more than diabetes. This is a high incidence and prevalence among the men and women. Men, the percentage is 9 to 12%. The female population, just note that Arna case presentation, they clearly mentioned 5 to 7% of the female population are suffering from sleep apnea. Atypical presentation of insomnia, not ability to proper sleep. Rule out sleep apnea is one of the important conditions. Commonly, we see day-to-day practice, hypertension uncontrolled, diabetes uncontrolled, asthma uncontrolled, cancer. There is a link between the cancer and sleep apnea. There are a lot of diseases associated with the respiratory. One of the common comorbid conditions we see is the sleep apnea. Only in practical way, in the respiratory care, in the primary care doctors, so the knowledge of sleep medicine is very almost zero level. So we have to create a lot of awareness about, because sleep apnea is a malignant disease. We don't treat, this patient may end up with a heart attack, stroke, sudden death during sleep. So these are important things we have created wonderfully. We have awareness program today. That's why the World Sleep Academy conducted every year World Sleep Day in the month of March to create awareness among the general populations and our own doctors. Very important. This is my take on this sleep and the respiratory system related issues. Yes.
Thank you, sir. I think we'll go on to Dr. Shaktish. Shaktish, I think you run a snoring clinic, right?
Yeah.
See, not everyone has, OSA going on. There are people who come to you saying this, I have snoring, and is it all about OSA, or there are some techniques to just reduce snoring?
See, before we brand a person as a simple snorer and obstructive sleep apnea, we have to first evaluate the patient. So we have to recognize the condition. And many times it not, as Dr. Jayaraman sir has pointed out, the presentation may not be a direct presentation. The patient might have been coming to some other completely unrelated condition. So we have to pick up the patient and identify this snoring and obstructive sleep apnea. And if we find a patient who has been established by polysomnograph as a simple snorer with no obstructive component, and generally what we advise is, if the patient is obese, we advise the patient to reduce his weight, and we advise certain positional. So generally certain patients do well if they sleep on the lateral instead of prone or supine. They do well in the lateral position. So, but before you offer those things, you should be absolutely convinced that the patient is only a simple snorer.
Thank you, Shaktish. The next question will go to Dr. Padma. See, nowadays children study late in the night. I think when they have exams, they study 2 o'clock, 3 o'clock. They don't study towards the evening and finish it off. And then during the pandemic, there was hardly any school there, and people just kept playing, watching TV all through the night. So children do that very often. Does that impact their health? And if so, what are the common problems that you observe because of this?
Most common problem is the cumulative sleep deficit. That is what we see. See, when they sleep late, they get up late, they continue to get up late, and then there's a sudden pressure on them to get up on time. They have got social responsibilities, they need to go. So then they start getting up early. What happens is that they go into a state of sleep debt. And like as we said, heard earlier, surgeons sleeping off during the surgical procedure. What happens is that when there's a continuous sleep debt, then there is a micro sleep, which even the and awareness, there are behavioral problems which come up, and children don't manifest as much with daytime somnolence, but like rather, as Dr. Shivaprakash said, they activity, they become more restless, they become more fidgety, and they have mood disorders, and then they forget things when they really need to go to school. So it is not only cognition, memory, but also the non-medical aspect which comes into play. They forget their notebooks, they forget their classes, they're not well made up. So both the combination of medical and non-medical aspects come into play, which leads to learning issues, academic issues, which if not identified as being due to the sleep problem, they're addressed differently. So that most important problem that we face with this delayed sleep-wake cycle.
Thank you, ma'am. Next question is to Dr. Shiva. See, if someone were to be advised about good sleep habits, what are the most common things that you will say, okay, kindly do all these things, and this is the way you practice good sleep?
Right. Thank you for bringing this up. And as it's been talked by all surgeons, physicians, psychiatrists during this entire presentation as to the importance of sleep hygiene. So the first and foremost thing to explain to any individual who comes to you with complaints of sleep is as much behavioral as it is biological. So just thinking about treating the biology is not sufficient. There is a significant behavioral component. So we can think about it as activities being done during the day. The easiest and the most important is physical activity. Unless a body is tired, it's very unlikely that they would get sufficient and appropriate sleep. It's possible to fall asleep, but that appropriate depth of sleep may not be possible. The second thing is reduction of stimulants. We talked about caffeine, but we tend to forget that lots of caffeinated drinks are available, which we don't even think of them as containing caffeine. For example, sodas have got a lot of caffeine, and so on. So reducing or stopping caffeine is really important. Similarly, during the day, it would be helpful to reduce smoking. It has positive benefits on both the general health of the health and well-being and increases exercise tolerance, but it would also reduce the stimulant effect. Then would be the process of getting to sleep. So over there, we can think of things like ensuring that bed is restricted only for sleep and sex. We end up using the bed for watching TV, finishing homework, reading books, playing games, chatting with family members, telling stories. We do it for everything. Bed is meant only for sleep and sex. And it might be helpful to even tell family members to lock the bedroom door, put a lock on it, and just leave it locked. Because otherwise people tend to just use it, and especially during the pandemic, people have used it in all the time. Next is setting into a routine to fall asleep. So our brain cannot switch off immediately. It's not a light switch on and off. We have to gradually progress to sleep. So extra exposure to daylight during the day and reduction in artificial light as we go towards the evening. Preferably at least an hour before wanting to sleep, it would be helpful to turn off all electronic backlit items. The next important thing is having a sort of stress reduction. So the psychiatrists before me have talked about mindfulness. Mindfulness or meditation is not only about gaining knowledge and gyan, but it is also about helping oneself slow down, calm down, and hopefully get to sleep. So it might be helpful to maintain a diary, which we call as a stress reduction diary. So all the concerns that you have in our mind, putting it on a piece of paper and keeping it by the side of your bed, so that once you go into bed, it always helps to say when there is nighttime awakenings, to say something like, I've written it down, I'll deal with it tomorrow morning. Rather than starting to think in the middle of the night, it's always helpful to just write it down and keep it by the side. Same time to bed, same time to get up. And most important, it is important to recognize that certain substances like alcohol can help people fall asleep, but it is very bad at maintaining or sustaining sleep. So it is really important to take substances out of the picture. People think that, okay, it's only a Friday night, it's only a Saturday night. One bad night of sleep can accrue a lot of sleep debt, as has been talked about already. So keep that in mind, that sleep hygiene indicates towards the behavioral aspects, not just the biological aspects. Thank you.
Thank you, Shiva. I think next question will be to Dr. Jayaraman. If I'm a primary care person and I just want to know the symptoms that I will check for to suspect obstructive sleep apnea, what are they?
Okay, fine. There are a lot of clinical questionnaire, very easy to remember. Stop bang questionnaire. This is a very easy to remember. There is a snoring. You would ask any patients with a snoring, and you have tiredness and fatigue, and you have any choking sensation. You would ask a bed partner any choking sensation or any gasping during sleep. You would ask bed partner, and high BP, obesity, increased body mass index, and short neck and increase in the neck circumferences. So these are the common clinical questionnaires. Snoring is very, very important symptom. Daytime excessive tiredness and sleepiness, and choking sensation, and sudden gasping breath during nighttime. You ask bed partner, and the high BP, obesity. Any patients walking into the OPD with the obesity, the first respiratory question you would ask is, do you have a snoring issue? Do you have excessive daytime sleepiness? Or do you have any tiredness, fatigue? Or you have any insomnia? Female population, you would ask headache, very important symptom. And insomnia, inability to sleep, lack of sleep in female population. These are all the common questionnaire. There are a lot of clinical questionnaire available, stop bank questionnaire, Epworth sleepiness scale to assess the daytime excessive sleepiness, and we have Berlin questionnaire, common questionnaire. Snoring is there or not? Snoring is in our place, layman terminology. Snoring in sleep in our people, yeah, good sleep, yeah, nalla thunguranga, nalla kottapodu thunguranga, good sleep we are thinking. No, this is wrong. As Dr. Pandey, you have to explain to the layman, and we must have a lot of program. We do sleep walkathon. IMA did a walkathon, several program in our areas. So create awareness. Snoring. There are simple snoring and sleep apnea snoring. Anybody else having habitual snoring, we have to exclude obstructive sleep apnea, because OSA has a lot of impact on all the system diseases, multi-system diseases. So it causes brain stroke, hemorrhagic stroke, high BP, heart attack, a lot of complications. So simple questionnaire, very, very important. Confirmatory test is portable level 3 polysomnography. Very, very easy nowadays. Previously we call it as a screening test for sleep apnea. Now, as per the American Academy recommendation, clearly mentioned, level 3 polysomnography, that is a portable study, bedside study to diagnose the OSA, sleep apnea. If any false negative, or we have to go for the level 1 or level 2 study to confirm further. But majority, 98% of the patients we diagnose using the level 3 polysomnography. So clinical questionnaire with the level 3 polysomnography, which clinch a diagnosis. That's all.
Thank you, sir. I think you have partly answered the next question as well. I think to Shaktish, I will put it this way. When do you recommend level 1 polysomnography?
So when your clinical assessment of the patient and the level 3 polysomnograph don't correlate. So we are expecting the patient to be an obstructive component to be pronounced. You have excessive daytime sleepiness, witnessed apneas, but you on the level 3 you're not getting the same interpretation. Then that means something has gone wrong. The simple thing is you just ask the patient, did he sleep well during the sleep study? So that is one thing which is often overlooked. We just see the sleep study, but we forget to ask the patient whether he slept well, because the main reason why level 3 sleep study is promoted these days, as you might have seen from a lot of presentations previously, doing level 1 and level 2 involves keeping a lot of probes on yourself. So it's not very easy to sleep, but fortunately these obstructive sleep apnea patients tend to fall asleep easily. So that's why you're able to do all those tests with all those leads. So, but still, when you are dealing with a patient with a very less obstructive component, the patient might have not slept properly. So when he's not slept properly, obviously the study is going to underestimate the problem. So if your clinical thing and your obstructive sleep apnea report don't correlate, that's a reason to advise for a level 2 study.
To Jayaraman sir, how commonly is a BiPAP or a CPAP recommended for an OSA?
Yeah, the obstructive sleep apnea management usually multidisciplinary. Once you confirm by clinical and the sleep study report, yes, OSA. So treatment is multidisciplinary. The gold standard treatment is CPAP. There is a positive airway pressure, either CPAP or BiPAP. CPAP majority 95% works. Some patients, overlap syndrome like any comorbid condition, severe heart failure or lung failure, COPD exacerbation, obesity, hyperventilation, type 2 respiratory failure, we give bilevel support. Or intolerance to CPAP, we give the bilevel support, BiPAP. This is the common gold standard. But the multidisciplinary, young patients, middle-aged patients, mild to moderate disease, we have to see as a patient's curative index. We send the patient routinely to ENT colleague to evaluate the upper airway to see any anatomical abnormalities. any correction to be done in the form of any coagulation. That is coablation technique or laser assisted techniques and the expansion perineoplasty. There are humpty number of surgeries are available. In a case of mild or moderate, young or middle individual, we see the patient as a curative intent. We refer the patient routinely to, before applying the CPAP therapy or BiPAP therapy, we evaluate the upper airway by putting the nasopharyngoscopy, that is a DICE, drug-induced sleep endoscopy. And if necessary, we, ENT people, they refer to the dynamic MRI, sleep MRI to find out the level of obstruction. So this way, we usually, approach these conditions. Any obese, morbid obesity, we send the patient to bariatric surgery. That's why I told treatment is a multidisciplinary. So chest physician is the lead. CPAP is a gold standard, but the adherence rate of CPAP is only 50 to 60%. Remaining 40 to 50%, they may not wear the mask. Nowadays, we have wonderful spatial interface, nasal pillow, nasal mask, auto-adjusted CPAP. It is soothing the sleep. There is a Philips Dream Station. There is a lot of advancement in the interfaces and machines, auto-adjusted. It give a proper mannerism. There is no, we have wonderful gadgets. Despite gadgets, CPAP, so still some of the people we see as a curative treatment. We have as a curative intent. That's why ENT colleague is there, bariatric colleague is there, oral and maxillofacial colleague is there to correct the maxillomandibular advancement. There are a lot of procedures, corrective procedures. Severe hypothyroidism, we correct the hypothyroidism level. Morbid obesity, bariatric surgery. ENT colleague, they are doing wonderful, plenty of surgeries. So, in my experience, any patient before CPAP, I refer the patient to ENT colleague to assess the upper airway, any anatomical block or dynamic block. If necessary, they will go for the dynamic MRI and see. Yes, Dr. Jairam, you proceed with bi-level support. This patient is not a candidate for surgery. Then I'll prescribe, I'll educate the patient about the CPAP, how to use, how long use. As per the recommendation, 4 to 5 hours wearing of mask during sleep is more than sufficient. So we do CPAP trial using auto-adjusted CPAP. So this way we educate the patient and proceed with the sleep apnea management.
So the next question is, thank you, sir, to Dr. Pichumani, sir. See, while prescribing people with insomnia, when we prescribe other medicines, right, for diabetes, hypertension, asthma, etc., are you very careful regarding choosing certain drugs when you prescribe these medicines for people having comorbids?
I think I answered the question partially in the previous thing, sir.
Yeah.
I think it's very important. Actually, I want to add on a few drugs like quinolones you are giving. Certain quinolones can definitely keep you awake. And the rheumatological problems, you give hydroxychloroquine. All those drugs actually can make the patient awake for a longer time. And that's the problem. So again, these drugs need to be actually considered before giving it, or at least to be consulted with a specialist. Consultation need to be sought instead of just keep on giving a sleeping pill. Because giving a sleeping medicine itself for a patient who has got a problem like he may fall, 60, 70-year-old man, they can have a fall, they can have go for a fractures and so on. So that itself is a thing, and so we have to analyze it properly. And as GPs should not just let them give a hypnotics and send the patient out. And as I already pointed out, antihypertensive drugs, especially when the patient is waking up in the morning, the night hours, there is going to be a physiological blood pressure reduction during night hours. Like there will be the reduction of 10 or 20 millimeters of mercury in during sleep. So that time when the patient suddenly wakes up, it can cause the postural hypotension. So you need to be careful. Sometimes you may have to run ambulatory blood pressure monitoring. We are actually doing for many patients nowadays ambulatory blood pressure monitoring also. Ambulatory blood pressure monitoring certainly helps to titrate the medications for hypertension in the proper way and to introduce medicines properly, whether to dying during night or daytime and so on. Of course, one more advice and request for our practitioners is don't use triple drug combinations and so on in many patients, especially in older individuals. Just for the sake of compliance, we keep on adding all the drugs together and give. Sometimes it overacts in the night and can cause the side effects like in the form of hypotension and the form of excessive diuresis, because they're going to add 3 drugs at a time, and both in the morning and night, one can cause more problems in the night that can produce a sleep disruption and can cause a lot of troubles. So I think it can run for pages. There are a lot of things are there in our practice. So I would always put it this way: we have to be very careful in choosing medications. for elderly patients, especially in diabetes, hypertension, and cardiac problems. And definitely, certainly, especially with the more and more patients in the BPH and so on, being prescribed alpha blockers and so on, they can suddenly aggravate hypertension. All these things we are seeing in our practice. So we have to be careful in giving any drug for that matter in the age. And of course, the quinolones also can be added in the list. Thank you.
Thank you, sir. Next question is to Dr. Shiva. See, there are people who have sleep problems and they address it in their own ways. There are people who have alcohol, then increase it, continue on alcohol, saying it's for sleep. And there are other group of people who use benzodiazepines and increase the dose as the days go on, and they are on those drugs forever. And I got a question from the floor that if someone is worried about developing Alzheimer's because of using benzodiazepines, how to address these people?
Okay, so after having talked about the behavioral component, now you are asking me to talk about the biological component. It's really important to recognize that alcohol and benzodiazepines, most sedatives, work through a common pathway of the GABAergic pathway. At low levels, alcohol works more on the glutamate as compared to the GABA, so there is that initial intoxication or the kick as they refer to, and which is also very commonly seen as mentioned by the pediatrician earlier on, who had talked about paradoxical agitation when we give benzodiazepines to children. Right? It is only at the higher doses that the GABAergic activity kicks in, and then it causes sedation. As mentioned previously, alcohol helps with sleep onset, but sleep maintenance is extremely poor with alcohol. And what you very rightly said is that there is a development of tolerance. So there is a receptor downgradation of both the GABAergic receptors as well as increase of the glutaminergic receptors. So in order to prevent problems with sleep, progressively people tend to use alcohol and benzodiazepines. Alcohol withdrawal is potentially dangerous. Benzodiazepine withdrawal is potentially dangerous. Do not try to stop it willy-nilly. Just don't stop it. It is important to consider a gradual taper of the medications, but also keep in mind that it has to be replaced with other sorts of behavioral components which we talked about. In terms of pharmacological treatment, there was a discussion about how the Z class of drugs, the zolpidem, zopiclone classes of drugs are sometimes used. But again, we have other sedatives which work through alternative mechanisms. But again, it's important to keep in mind that a gradual reduction with a cross taper to behavioral components or behavioral treatments is important. Also, alcohol and benzodiazepine dependence are medical illnesses which require appropriate medical interventions. Of course, there is a strong psychological component which needs to be addressed, but it is important to recognize that these aren't people who are just doing it because they have nothing else to do. So they are not getting drunk because they have nothing else to do. Approaching them with a calm, patient mind and finding out their concerns. It might be that they may have some mental health issues. It may be that they may have some associated problems, which, if appropriately treated, can improve both their physical as well as their mental health. So the long and short of it is gradual reduction, keeping in mind that withdrawal from benzodiazepines and alcohol and sedatives is dangerous. So,
thank you, Shiva. I think we'll go through rapid questions. The next 4 questions would be the last. Continuous night shift, what is the impact on health, Dr. Pichumani?
Yeah, actually, continuous night shifts definitely increase the pressures on the patient. Is a big stressor for the patients. Certainly, diabetic patients is a big menace for us when we are discussing about the lifestyle. It's quite difficult to manage lifestyle, and they don't go for walking because of the continuous shifts like morning, day, night, and 3 shifts and all. It's very difficult to manage. And I used to tell my patients above 40 years, it's a recommendation by Many of the company people also, they say, I would say above 40 years, I think better they are not injected than for the night duties. Definitely it worsens blood sugar control as well as blood pressure control and so on.
To Dr. Padma, what are the neurological conditions associated with sleep disorders in children? No, please unmute yourself, ma'am.
Disorders are very common in children with neurological conditions. They have very higher incidence in children with cerebral palsy. But what we more commonly see are the sleep-related movement disorders. So these are mostly seizures and non-seizure events. So on the non-seizure, we also have the behavior, normal physiological phenomena of benign sleep myoclonus of infancy, which invariably gets labeled as a seizure. And then we have this big list of parasomnias, confusional arousals, which are again sometimes misdiagnosed as seizures and treated with AEDs. Then we have a big list of nocturnal seizures, which like these Rolandic seizures, we have the Peniotopoulos syndrome, and then we have the frontal lobe epilepsies, which always cause some diagnostic confusions. And then we have sleep deprivation as the biggest trigger for children who are even well controlled with epilepsy. So when we see that when they undergo a period of sleep deprivation, then invariably then there is an increased frequency of seizures. So sleep and neurological conditions are very closely related. Then there are a big subgroup of neurodevelopmental disorders. Like, for example, we have the Rett syndrome, in which sleep is a big issue. We have the Prader-Willi syndrome, in which you have the upper airway obstruction, the OSAS, which is very common. So sleep and neurology and neurodevelopmental disorder is a big interlink. That is what I would say. Then we have children with ADHD. We have children with autism. Children with autism have extreme sleep problems, in which we find it difficult to manage. Apart from your sleep hygiene, we end up using several drugs also for management of sleep in them. So that is what I would say in a nutshell.
Thank you, ma'am. Next question is to Dr. Shiva. For someone who's on continuous night shift or occasional night shift, how should he plan his daily schedule?
Right. If somebody is on a continuous night shift, it is probably better than a phase shift. So 1 week of night, 1 week of day, 1 week of afternoon, it is so much better to have a continuous night shift. Preferably follow the same rules of sleep hygiene as was previously described, which is make sure that there is a closed environment, complete darkness when you do come back from your workplace, and do not expect to try to run your daily schedule as if it were both you are working at US time as well as Indian time. It is not possible. It is extremely dangerous. The next important thing is it is extremely important to consider engaging in physical activity in the evening times before they go to work. So many a time they tend to get up right before they have to go to work, and pasanga school kalambra madri, they will have a quick bath and they'll be. It is important to engage in physical activity and start the day with that physical activity. Alcohol is used, benzodiazepines are used, again extremely dangerous because it is a slippery slope. So keep in mind that if you are working at a different time zone, which is completely out of sync with your current time zone, your existing time zone, act during the time when you are working as if it were day. So exposure to light, physical activity, if required stimulants, but at the other time, reduction of light, complete sleep, and dedicating the 6 to 8 hours of full-time sleep for day-to-day, for being able to function better.
Thank you, Shiva. The last two questions to Dr. Jayaraman. Is obesity a must for OSA?
Yeah, the cause of sleep apnea, 80% is obesity. 20% is the non-obese people due to the bony abnormalities like retrognathia and micrognathia and some intrinsic abnormalities. So majority, 80% of the patients, they have sleep apnea symptoms like snoring, excessive daytime sleepiness, and insomnia, and daytime tiredness, weakness, with the comorbid conditions like diabetes, all other metabolic diseases like syndrome X and syndrome Z and all. So obesity plays a major role in all the diseases. So 80% cause of obstructive sleep apnea is the obesity. So we have to address the obesity properly. Then only we can control other diseases like hypertension, diabetes, and osteoarthritis, etc., etc. So obesity as one of the major epidemic and diseases in the world, in the globe. So we have to concentrate more on obesity management. Yes.
Thank you, sir. Last question to Dr. Pichumani. Is OSA very common in rural areas?
Actually, I was about to talk about this when Jayaraman sir was addressing. Actually, it is 10 years back we never heard of OSA in our setup, sir. Actually, I've been even the day for yesterday we had a sleep study done in the hospital, sir. So at least nowadays I feel there are at least 4 to 5 patients where we are doing a sleep study in our hospital per week, sir. It's very high. I couldn't believe myself, and I've been just asking the ENT specialists, everyone to come and talk to us. And again, I'm sometimes thinking, am I overdoing it? But it's happening. But I couldn't believe it. So that is the problem. And actually, many are not very obese at all. Sometimes the abdominal obesity is always there. I have seen it, but not like short neck and so on. The classical definition that we used to have. The few people I have seen. Moderately built, they're having the snoring and sleep apnea and so on. So it's quite dangerous. And I have actually seen recently one hypoglycemia patient because of that and severe hyperglycemia. We did a study, and then we CGMS we had done a CGMS in the patient, and then we actually asked the relatives. They told the patient is having a sleep disturbance at night. He gets up in the night and starts suddenly shouting and so on. So as you rightly pointed out, it's not less in rural area, and faster urbanization probably is the reason. No longer the practicing area where I'm practicing right now belongs to rural area. It's more of urbanized. So I think we are encountering more and more patients. More and more awareness needs to be given to general practitioners practicing rural areas about this. It was quite right on the part of Jayaraman sir talking about that. It needs to be done more and more, sir. Thank you. Thank you for the opportunity.
Thank you, sir. Thank you, Dr. Jayaraman, Dr. Padma, Dr. Shiva, Dr. Pichumani, Dr. Shaktish. It was wonderful. And you had, I think, some other meeting on for most of you, and you had to stay back late. Sorry for the delay. Thank you for the knowledge sharing. Thank you so much.
Thank you very much. Thank you for the opportunity. Namaste, madam. Namaste, panelists. Thank you, Tambaram.
Thank you.
Thank you, AMS. Thank you, Shiva sir. Shaktish, Pichumani sir, Padma ma'am. Thank you, Hariharan sir. Wonderful moderator. Super. Thank you, madam.
Fantastic.
God bless. Be safe. Thank you, madam.
All the best. Bye.
I thank all the panelists and moderators for an elaborate and extensive discussion on sleep disorders and their management. We have learned a lot on sleep disorders, their treatment, and impacts of sleep disorder on one slide. With this, we come to the end of today's meeting. I now request Dr. Balaji to deliver the vote of thanks.
Hello. Yeah, am I audible?
Yes, Balaji.
Yeah, it's indeed my pleasure to propose a vote of thanks for this nice meeting that has been conducted without a glitch. I thank the patrons of the organized team, Dr. Panisami, Dr. P. N. Raja, Dr. Tyagarajan, Dr. A.K. Dr. P. Harirao, Dr. Sanjeev Singh Yadav, Dr. Narayana Mani, and the advisors, Professor V. Mudan, Professor R. Kannan, who gave us valuable tips, and Dr. V. Rajesh Babu. I also thank the office bearers of the Tambaram IMA, Dr. Nirmal Frederick Saranappa and Karthikeyan, and Dr. Hariharan, my secretary, for nicely suggesting the topics and the speaker and selecting and organizing the meeting without a hitch. I thank the IT contributor, Dr. Vijay Kumar, for helping us with the Zoom presentation. I thank the MCs of the meet, Dr. Vatsita, Dr. Sripriya, and Dr. LLC for conducting such a smooth program. I thank all the speakers who gave up their valuable time for such a nice topic and stayed together for such a long time for us. And finally, last but not least, I thank all the audience who have stayed with us for nearly 5.5 hours and made this program success. Thank you all.
Thank you, sir.
Thank you.
Right. Thank you all. Well done. Balaji, Hari, Saptesh, and I hope all the moderators are here. Vatsita, Edil, Sripriya.
Thank you, sir.
Kumar is
Thank you
there.
so much for giving us the opportunity, sir.
Well done, well coordinated event. Slightly overshot. So much information, the depth of information available on sleep. Right, we'll end the program.
Thank
I
you,
think
sir.
Hari has to end.
Thank you, sir.
Yeah.
Thank you, sir. Thank you, sir. Thank you, sir.